Welcome to the National Clinical Care Commission meeting. My name is Jennifer Gillison, and I am from Kaufman & Associates and will be providing support today. I will now turn it over to Kara Elam, DFO.
Good afternoon to some, good morning to others, but welcome to everyone to the National Clinical Care Commission's 12th meeting. Members, I will begin calling roll. Please let me know if you are present. Bill Herman?
Present.
Pat Schumacher?
Present.
Howard Tracer? Barry Marks?
Present.
Naomi Fukujawa?
Present.
Donald Schell?
Present.
William Chung?
Present.
Aaron Lapata?
Present.
Jana Town?
Present.
Barbara Linder?
Present.
Captain Samuel Wu?
Present.
Paul Conlin?
Present.
Ayatunde Dacombe?
Present.
Carol Greenlee?
Present.
David Sturbatz? Dean Schillinger? Ellen Leake?
Present.
Jasmine Gonzalvo?
Present.
John Boltry?
Present.
Meredith Hawkins?
Present.
Shannon Idzik?
Present.
Sherry Bolin?
Present.
Bill Cook?
Present.
Dean Schillinger? Bill, we do have a quorum. Please begin.
Good.
And
Thank you very much, Kara. Good. I want to thank you all, too, for your attendance today and welcome you to the 12th meeting of the National Clinical Care Commission. I also do want to apologize for scheduling the meeting on Rosh Hashanah. I'll turn the meeting over now to Dr. Dorothy Fink, who is the Director of the Office on Women's Health, for her opening remarks.
Good afternoon, everyone, and thank you so much, Bill. We welcome you all to the 12th and final public meeting of the National Clinical Care Commission. I am really excited about the discussions that will take place, as well as the final vote on what will be part of the Commission's report to Congress, a combination of all the hard work and dedication over these last 3 years to improve diabetes care and diabetes control. Reducing the burden of the current diabetes epidemic is a major priority for the Department of Health and Human Services, as 34.2 million Americans, just over 1 in 10, have diabetes. Equally alarming is the fact that 88 million American adults, approximately 1 in 3, have prediabetes. These statistics are why we are here today. We are seeing upward trends in diabetes rates for children as well, not only in the number of youth diagnosed, but also in the specific types of diabetes. While we have been in the past so used to type 1 diabetes, we're now seeing soaring rates of type 2 diabetes in children and teens. We appreciate all of your work that went into thinking about these significant clinical, public health, and financial health burdens that these pose to our nation. I, along with all HHS leadership, am excited to hear your recommendations for how we can all continue our work to eliminate this burden. As we move forward today with our agenda, it is my pleasure to introduce to you our next speaker and one of HHS's top champions for health, Dr. Rachel Levine. As the 17th Assistant Secretary for Health for the U.S. Department of Health and Human Services, Dr. Levine's work includes ensuring our nation overcomes the COVID-19 pandemic while building a stronger foundation for a healthier future. Dr. Levine's career began in public health and clinical care, first in academic medicine, and then as Pennsylvania's physician general, and then as Pennsylvania's Secretary of Health, where she addressed the Pennsylvania opioid crisis, maternal health, as well as improving immunization rates among children. Dr. Levine, I have really enjoyed working with you and am thrilled that you're joining us today to address the National Clinical Care Commission. We appreciate your support for the work in diabetes and all the meetings that we've joined together on so far this year addressing diabetes. And I will now turn things over to you.
Well, thank you so much, Dr. Fink, and good afternoon, everyone. It is really, truly a pleasure to address the National Clinical Care Commission on the opening of its 12th and final meeting. Today's meeting is particularly important as it marks the culmination of a 3-year commitment to diabetes prevention and control throughout our nation. And I want to share my deep thanks and appreciation of the time and energy that all of you have given to this effort. The vision began in 2017 when Congress passed the National Clinical Care Commission Act. That following year, the Commission held its first meeting in October 2018. Since that time, the United States Department of Health and Human Services has looked to the experience and expertise of this congressionally mandated commission to inform our Secretary, our Department, and Congress on federal programs in diabetes prevention, care, treatment, research, and education. The work to improve the continuum of care is so vital. Diabetes takes a very high physical and emotional toll on both parents and their families and patients in general as they cope with disease management across the lifespan. And psychological distress associated with diabetes has been linked to poor self-management of the disease and resulting health consequences. The cost of diabetes poses a significant financial burden on the United States healthcare system and on society. The total burden of diabetes was actually $327 billion in 2017, including $237 billion in direct medical costs and $90 billion in reduced productivity. As the Assistant Secretary for Health and a pediatrician, I'm very concerned about the crisis our nation is facing with diabetes. Now, I have seen myself in my clinical care the impact that diabetes can have on both children, adults, and families who are given the diagnosis of this chronic disease, which currently impacts and affects 1 in 10 Americans of all ages. If current data trends continue, 1 in 3 Americans will develop diabetes in their lifetime. And that is why HHS is committed to reversing this trend through improvements in federal diabetes prevention and treatment, as well as through collaboration with our federal partners. Now, I can't get through a talk in our current environment without talking about COVID-19. The COVID-19 pandemic has brought to the forefront the need to prioritize diabetes prevention on all fronts due to the greater increased risk of disease and death from COVID-19 from individuals with poorly controlled diabetes. HHS healthcare teams, as well as many NCCC members, have been on the front lines providing clinical and critical care for populations affected by the pandemic. HHS has also accelerated scientific innovations such as vaccines and COVID-19 testing for the safety and health of the American public. Our top priority right now remains staying ahead of the virus and protecting people in the United States from COVID-19 with safe and effective and long-lasting vaccines, especially in the context of a constantly changing virus and epidemiologic landscape. Certainly, if you have not already done so, I strongly encourage you to get your COVID-19 vaccine and to help others around you get vaccinated as well. Now, I want to talk about diabetes in terms of the social determinants of health and as an issue of health equity. We know that diabetes and its complications are more common and severe within low-income communities and communities of color. The HHS Office of Minority Health, the Indian Health Service, and HRSA, to name a few, are working to identify, educate, and assist populations at risk for diabetes and those individuals impacted by diabetes. About 2/3 of diabetes costs were paid by Medicare and Medicaid. Caring for people diagnosed with diabetes accounts for 1 in every 4 healthcare dollars, making diabetes the costliest chronic condition in the United States. We also know that effective medical care can actually prevent type 2 diabetes and help individuals with diabetes avert many of its complications. However, the social and environmental conditions that shape people's daily experiences in their daily lives have a huge impact on whether they develop diabetes, can successfully manage the disease, or suffer from its consequences. The department, therefore, continues to be very concerned about the prevalence of health inequities that contribute to and exacerbate greater risk of developing diabetes in lower income communities and communities of color. Reducing these inequities requires coordination across government agencies and with public and private stakeholders in healthcare, public health, agriculture, and supporting industries and sectors. This includes formally recognizing and addressing the deep inequities that are present within our health system that disproportionately impact some more than others, particularly communities of color and communities of lower income. Underscoring the Biden-Harris administration and this department's focus, I am in pursuit of a comprehensive approach to advancing health equity for all. Our goal here is to ensure that we address and prevent these inequities in the future. Health equity is a key part of our mission at HHS. Another of our top priorities at HHS is the impact of the environment on public health and its role in preventing chronic health conditions. Our environment has a profound and real impact on the health of our communities, especially as it relates to diabetes risk and prevention efforts. And that is why we recently launched a new Office of Climate Change and Health Equity, affectionately called OCHE. And we look forward to working with you to address the climate crisis that we're experiencing now and its impact on our health. Of course, critical to advancing these priorities is the continued investment in education and cross-agency coordination of diabetes care and prevention services. So today, we will hear the final recommendations and report from the National Clinical Care Commission. I want to commend the members of this commission as they take time today to discuss and finalize their hard work and efforts by actually voting on what will be the final commission report to our Secretary of HHS and to Congress. I look forward to your recommendations and your vision for ways that the federal government can ensure equitable access to diabetes prevention services and care. Now, it goes without saying, but we are all here, myself included, because we are motivated to improve health outcomes. The mission of our department is to ensure that all people are able to lead their healthiest and happiest lives. The work being done by you all through this commission is a critical part of realizing that mission. Your work is essential to us changing the landscape of diabetes control across the country. Thank you so much for the opportunity to speak with you today, and I will now turn things back over to the chair, Dr. William Herman. Thank you.
Thank you very much, Dr. Levine, for your comments and support. The work of the Commission has been the focus of our lives for the past 3 years, and we are really very passionate about it. We look forward to working with you and your team to disseminate the report to the department, to the Congress, and indeed to the American public. We're very proud of our work, and we believe it has the potential to address social determinants of health and health equity, and indeed address the epidemic of diabetes in the U.S. So again, we thank you for being here with us today, and we would really welcome the opportunity to work with you to disseminate our plan and to begin to see things happen. So thank you. Good. I will go on now with a brief review of the duties of the National Clinical Care Commission and a quick review of the agenda. Do we have the slides up? I've lost my screen.
Yes, they're up.
Okay, good. So the National Clinical Care Commission is a federal advisory committee established in 2017. Its purpose is to evaluate and make recommendations regarding improvements to the coordination and leveraging of programs within the Department of Health and Human Services and other federal agencies related to diabetes. Next slide. The specific duties of the National Clinical Care Commission include evaluating and making recommendations to the Secretary and Congress regarding federal programs that focus on preventing and reducing the incidence of diabetes, current activities and gaps in federal efforts to support clinicians in providing integrated, high-quality care to individuals with diabetes and its complications, improving the coordination of federal education and awareness activities related to the prevention and treatment of diabetes. Next slide. Exploring methods for outreach and dissemination of education awareness materials and identifying opportunities for consolidation of inappropriately overlapping or duplicative federal programs. Next slide. As you all know, the work of the Commission has been done by 3 subcommittees, including one focusing on prevention of diabetes in the general population, the second on prevention of diabetes in the targeted at-risk population, and the third focusing on the treatment and complications of diabetes. In addition, we've had a number of focus areas, including social determinants of health, access to care, and health equity. And each of these subcommittees in its report has addressed unmet research needs. So the next slide shows today's agenda. What we will be doing is reviewing and voting on the final executive summary, 7 chapters, appendices, and table of content of the NCCC's report to Congress, which must be delivered to the Secretary by September 30th. So we'll go ahead and get started. Jennifer Gillison will be showing the report as it is and highlighting questions that need to be discussed and resolved. So Jennifer, if you can go ahead with that.
Okay, does everyone see the PDF document in front?
Yes.
Fantastic. So the first one we have, and we will come back to vote on this, but the first question from Dean was the list of commission members, if the 2 ands, Bullock and Albright, should be listed here with an asterisk as contributors and commission members. Since they have retired. Now they are listed as previous co-chairs of the subcommittees in the appendix. So the question would be, do you want them also listed here?
Dean, do you want to speak to that?
No, I just like to know what our process is for voting. I mean, I think my comment is self-explanatory. And this seems like there should be some federal rule about this because people retire all the time.
And Dr. David Wong had been a member of the commission as well and was detailed to the COVID response team. So the question, I guess, would be whether to include him as having participated.
Right.
So is there a
So
reason
Jennifer,
that we cannot include them?
So I can say that typically the commission members are the current ones, and if there were any that had sat but say retired, that they are listed in the subcommittee ones and reflected that they were retired. But typically this is the list of current members.
And Kara, there's no reason that we could not include them?
As Jennifer stated, this list is usually the list of current members, where the retired members are listed elsewhere. So this is the list of the current. But you are able to vote as you would like.
and what is the process for voting for the rest of the day? How are we doing that?
So you follow the same Robert's Rules, right, of order. So once we review each of the chapters, someone would need to make a motion, and then there would need to be a second. You can have, additional discussion, and then you would call for a vote, and then each person would vote individually. And those votes would be recorded and part of the summary that we provide from the meeting. Sorry, my voice is going.
And I think, Jennifer, this is the only issue we have on this topic. Is that right?
Right. So we've gotten a couple. Yep. So we can go to the next thing. So just to mention that, Ellen, we do have your MBA and revising PATS to show MS. And we'll come back. We don't typically do the table of contents first, only because if there's changes throughout, we want to make sure it's updated. So we'll move on to the next thing. We have a comment from Pat in the executive summary that would pertain to the full report, is that when diabetes prevention is referenced, she would like you to consider type 2 diabetes prevention instead. So the question would be, do you need to look at that on an individual basis through each of the chapters, or can that be a universal change?
Are there examples where we did not do that? Because we have gone through the entire report with that in mind.
Yeah, Pat, would you like to address that if you have any areas that you thought it wasn't addressed?
Yeah, we do make a statement about it in the beginning of the report, but several of the headings throughout the report and the subheadings say diabetes prevention. I just thought we would be helpful to be clear with all of our language when we're referring to prevention, where it's appropriate.
This is Barbara. I agree with Pat. There are a number of places where that change has not been made, and I think it would be good to make it. Thank you.
One of the problems we have, I entirely agree, this is Dean, one of the problems we have is the phrase prevent and control diabetes and its complications. In that context, it is challenging to specify type 2 or type 1 or both. And so that catchphrase does appear quite commonly. The other example, when we just say prevent diabetes, I believe we have successfully changed all of those to preventing type 2. So, but there may be some that were missed. Is there a concern about the first phrase as well? That shows up in this paragraph that we're looking at, for example.
Yeah, I think in a number of places we've changed that to read prevent type 2 diabetes and control the complications of diabetes, being more generic. So I think the point is well taken. It doesn't sound like there's any disagreement, and I think we should go through and try to be as explicit as we can. When we are talking specifically about preventing diabetes, I think it should be made prevent type 2 diabetes. And I guess I would make a motion to that effect.
I would second it. Ellen?
All right, this is Bill Chong. Just a quick question on that. I know in some of the research sections we do talk about research related to type 1 diabetes, just to be careful that we don't make any adjustments there that might be actually relevant to maybe commenting on type 1 diabetes prevention.
Absolutely. We can't just do a...
Yeah.
Yeah. That's
we can't just do a find and replace.
Okay. Jennifer, was there anything else for this section, or should we vote on these two motions?
So you do have the motion, so you do need to vote on that motion, and then we can review the executive summary.
Okay, so the motion is to be specific when we talk about prevention of type 2 diabetes to state type 2 diabetes, rather than just the prevention of diabetes. Do we need to do a roll call, or can we have a voice vote on that?
You can either do a voice, or we go through all of the names.
Yeah, so if people can unmute their lines and all in favor, please say aye.
Aye.
Aye. Aye.
Aye.
Aye. And all opposed, please say nay. Okay, good. So I think we agree to that. What was the next issue, Jennifer?
Okay, so then we have, so this page, let me make it a tad smaller so you can see it. So there weren't any on this first page here. Then we get into this here, which is the overarching recommendations. So Bill, you had said that you felt the paragraph was still garbled and needed to be revised.
Can you pull that up? I can't see it.
Yes, so do you guys see this, the overarching recommendations, the PDF?
No, I'm seeing the contributions.
Yes, I see it.
Yes.
Yes.
And Jennifer, I sent a revision that might be helpful.
Okay, was that today?
Yesterday.
Okay, can you tell us what? Oh,
Yeah, very simply, very simply, it shouldn't say making, it should say make.
Right.
And there should be a comment after medical treatment.
So
Okay.
I had an alternative wording to that. It seems like it's a run-on sentence. And I would phrase it as historically diabetes prevention and treatment have been considered to be medical problems requiring medical treatment, period. Limited attention has been paid to the social and environmental conditions that contribute to type 2 diabetes, making management, where we're just actually period there, to make to facilitate diabetes awareness, prevention, and treatment. Type 2 diabetes should be addressed as a societal problem. Additional federal efforts are needed to improve access to health care and to address the social determinants of health, and additional trans-agency collaboration is required.
So this is Barbara. I'm fine with we should make sure that we don't limit the issue of social determinants of health to type 2 diabetes because, you know, as you
Exactly.
know, there are tremendous disparities
Yeah,
in
good
type.
point.
Yeah.
So the question would be is, does the commission agree with what you just stated, Bill, and they are in agreement to change this paragraph to what you just stated?
Well, as it's written, I just honestly, even changing making to make, I don't understand. It doesn't make sense to me.
Yeah, Bill, this is Dean. I like what you were doing with breaking up the sentences. I would caution us from moving much beyond that because I think that, for example, Barbara's concern is not an issue in the way it's currently written. So I like the breaking up the sentences. I think the rest of it felt like a bigger edit that we would need to process and we need something in writing to respond to. It would take time. In other words, saying historically diabetes prevention, blah, 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 requiring medical treatment, period. Limited attention has been paid to the social environmental conditions that contribute to type 2 diabetes and make managing diabetes more challenging, period.
Or actually get rid of type 2. Yeah. But then in the third sentence, I would specifically state the issues of addressing social determinants of health, access to care, and greater trans-agency collaboration.
Yeah, and that's there now. Exactly those words.
But you're not going to address social determinants of health through trans-agency collaboration. That's not going to, agencies working together is not going to do anything necessarily about social determinants of health.
I see. You wanted to say and trans-agency collaboration?
Yeah, the three issues are addressing social determinants of health, improving access to health care, and increasing trans-agency collaboration.
Fair enough. Fair enough.
Okay. Other comments on that?
So I just want to make sure that I have it. So again, historically, diabetes prevention and treatment have been considered to be medical problems requiring medical treatment, period. Limited attention paid to the social and environmental conditions that contribute to type 2 diabetes and making managing diabetes more challenging, period.
It should be limited, has been paid.
Has been paid.
Right.
You're missing the has.
Limited attention has been paid to the social and environmental conditions that contribute to, do we want to say diabetes or type 2 diabetes, period?
I would favor just saying diabetes here.
I agree.
Carol, I agree because there's other types of diabetes that this has a huge impact on.
Okay, so it sounds,
And then,
okay, so it sounds like
And
there's an
make-
agreement to take out type 2.
And then you say, and make managing diabetes more challenging.
Okay.
and then the third sentence would be to improve diabetes awareness, prevention, and treatment. Additional federal efforts are needed to improve access to health care, address social determinants of health, and facilitate or improve trans-agency collaboration.
And improve trans-agency collaboration, right?
Correct.
Okay, so just read it all again so everyone's on the same page. Historically, diabetes prevention and treatment have been considered to be medical problems requiring medical treatment, period. Limited attention has been paid to the social and environmental conditions that contribute to diabetes and make managing diabetes more challenging, period. To make a more significant impact on diabetes awareness, prevention, and treatment, additional federal efforts are needed to improve access to health care, address the social determinants of diabetes, and improve trans-agency collaboration.
So the to make a more significant impact could be deleted to just read to improve or to improve diabetes awareness, prevention, and treatment.
And can we say social determinants of health rather than social determinants of diabetes?
I agree.
You said determinants of health, right? Not diabetes?
Yes.
Okay, so I just want to make sure to improve the impact on diabetes awareness, prevention, treatment, additional efforts are needed to improve access to health care, address the social determinants of health, and improve trans-agency collaboration.
So it's just to improve diabetes awareness. There's no impact on.
Okay. So is there agreement to now replace this paragraph with this new edited paragraph?
Yes.
Is there anyone who disagrees with that? Okay, fantastic. I'm just typing to make sure I've got it. Okay. All right. So we will make that change to that paragraph. The next, sorry.
I'm sorry, just a quick question. Can you, this is Sherry, can you hear me?
Yes.
Yes.
If you scroll back up, then you have these 3 bullets after the change. Do those still make sense? Because the way the last sentence was worded, it was worded like the following. Are we keeping the last sentence in? I would assume. I just wanted to double check we were keeping it in, because otherwise it wouldn't make sense, I think, to go into the...
Yes, I think the last sentence was to remain in.
Okay.
Okay. So let me scroll down. I believe that was the last comment for the executive summary. Were there any other comments that were not captured here that need to be addressed? Otherwise, that is the review for the executive summary. If someone wants to make a motion to accept it with the changes that we made.
John Boltry, a motion to accept the changes that were made.
And approve the chapter,
second.
right? Thank you. Do you want to call the vote, Bill?
Yeah, all in favor, please say aye.
Aye.
Aye. All opposed, please say nay. So the motion carries.
All right. So we'll move on to the first chapter here.
So Jennifer, I think we should also have a vote on the contributors. And I would, I guess, like to propose that we include everyone who was a member of the National Clinical Care Commission, so to add those 3 people that we mentioned.
And
Okay.
this is John Boltry. I did not see Ann Albright listed as a co-chair, former or retired co-chair of Prevention Targeted Population. So if we can add her in there as well.
Okay, so you have a motion, Bill, to add the 3 contributors to the table of contents page under contributors.
Correct.
Okay.
Do we
either-
need to? This is just a question. Do we need to footnote that at all because they weren't able to vote on it at the end?
Well, they would have to be like accurate to say they were retired.
Okay.
Jennifer, this is Tara. Can I just ask that you would like to vote on the table of contents last? So will this interfere with that, or should we hold off on that vote?
Well, there's a motion on the table, so it needs a second. But for the motion, yes, you could do that as the contributors, and then we still have to go back and see if there's any additional changes that need to be made based upon the chapters as we move through the chapters.
So I do see it's on the agenda later, so I can withdraw the motion.
Okay.
All right, so let's keep going with the executive summary.
Okay, so executive summary was done. You did have John Boltry made the motion to accept the changes. I think that also means the chapter, but he would have to clarify. Bill
Okay.
Chong did the second, and then there was unanimous.
Okay, I'm sorry. So let's go to chapter 1.
Yep, so chapter 1, so we have here so the first note is that the 3 paragraphs on type 1 and type 2 were added by Bill based on Barbara's comments. So the question would be, is there any changes or any disagreement with these 3? It was the first time that anyone had seen these 3 paragraphs. And if there's not, then we'll go to the next one.
All right, let's keep going.
Yep, and so you just made a comment about adding B, which is fine. So then this paragraph is added based on Dean's suggestion. Bill had suggested placing it after the description of type 1 and type 2, but Dean suggested it be moved up. Bill and Dean, you also added clarifications around the type 1 and type 2 in the executive summary in chapters 1 through 4. Naomi had said that it was a good add. David Shogratz did say that he preferred the suggestion of leaving the paragraph after the descriptions of type 1 and type 2. So the question on the table is, do we move it above, or do we leave it where it is?
I think it makes more sense to leave it after we describe the types of diabetes, so where it is. Dean, did you?
Right.
I'm fine with that.
Okay.
Okay, any disagreement?
No.
Fantastic. So we'll leave it where it is. Nice. All right, we will go to the next one. Okay, so this one here, the paragraph was added by Bill and Pat based on Dean's suggestion. Barbara did make a note that NIDDK co-funded Search and Triad, and could this be edited to reflect that? So where would you want that to be, Barbara?
Well, if it's okay with Pat, it could just say Search and NIDDK began the Search for Diabetes in Youth program, blah, blah, blah.
Yeah, right after in 1998. Mm-hmm.
Yes.
CDC and NIH, or do you want to say NIDDK?
No, I mean, if the preference is for NIH, that's fine. It doesn't have to be NIDDK.
And that applies to translating research into action for diabetes
Right.
as well.
Yeah, if you just added it at the beginning of the sentence, it would cover both.
Okay.
Yes, and Sorry, while we're on this sentence, I also recommended that we include the Next D initiative, which was evaluating diabetes-related policies, a very important thing. I'm wondering, Pat, whether, and Barbara, why we shouldn't mention Next D.
This is Pat. I'm fine with including Next D.
I am as well.
Okay. All right, so this new sentence will just say NIDDK and CDC began, right? And then
No.
after...
But I would put...
No, in 1998, yeah, CDC and NIH began the search for diabetes in youth.
Yep. Okay, so it's CDC and NIDDK. Okay. And then...
NIH.
NIH.
Oh, sorry. All right, we'll change it to NIH. Got it. Okay, NIH. And then what you were saying is before this sentence in the response to, right, this is where you wanted NIDDK and CDC also co-funded the Next D initiative. Is that correct, Dean?
I would put it
CDC
after the...
and NIH also.
Yeah,
After
I think you can, yeah. I sent some a half of a sentence to you yesterday, Jennifer, that has the language for the Next D initiative and what its purpose was. I don't remember. I don't think it was 1998 that was launched. It was a different year, but it is about 8 words long.
Yeah, this is it right here that I just pasted. And you had it just before this in the response to. So it came after this sentence. And then add this one, which now says NIH and CDC also co-funded the Next D initiative to evaluate the effects of type 2 diabetes-related health policies and interventions on various populations. And then it would go into in response to findings from the DPP, et cetera, et cetera. Is that?
That's correct.
Is there any? Okay. Is there any
this is
disagreement?
Barbara. I would just flip it and put CDC first, since they were, nominally the leader. So it would be CDC and NIH rather than NIH and CDC. I mean, it's
correct.
Minor.
Okay.
I feel, yeah.
Okay, and no disagreements, correct? Okay, not hearing any. All right, so we have marked those 2 changes. Then we come down to this one here.
I'm sorry, but before we move on, was PCORI also involved in Next D?
Not to my knowledge.
Pat, do you know? I personally was not involved.
I don't know offhand. I would have to go back and check.
Okay.
I can look it up.
There were many partners involved in Next D.
So Barbara, does that mean there would be language to add to this new sentence? Is that correct?
Well, if that's maybe we can try to figure out if actually that's true. I have sort of
No, I can tell you, Barbara, some of this Next D sites were part of PCOR-Net. So the research network was a PCORI-funded network, but the investigators working in the network were funded by CDC and NIDDK. So that's a...
Okay, great.
Yeah.
Thank you.
So I would leave it as is.
Yeah, this is Pat. I agree.
Okay, great. Thank you for clarification.
All right. Okay, so the next one we have here is this paragraph. So this is the revision based on the OWH's team's comments and suggestions. Bill expressed preference for the original language. Naomi has said she prefers it how it is written. However, Howard provided some additional thoughts, and he said he thinks insufficient engagement among federal agencies should be changed. Insufficient engagement sounds to him like don't care, and the HHS agencies are very engaged and care very deeply about their mission in improving health. For HHS agencies, insufficient coordination is appropriate. If insufficient engagement is referring to non-HHS agencies, that should be made clear. Perhaps adding some to the effect that non-HHS agencies don't recognize promoting health as part of their primary mission or don't recognize how their activities affect the health of Americans. Dave Strogatz said that he was good with the language of insufficient engagement. So the question would be is, go ahead, Dean.
And Jennifer, I had provided a response to Howard to accommodate the concern. Do you have that?
No, I don't.
Okay, it was specifying the non-health federal agencies, which is the concern that he has.
So did you suggest wording to him?
I said insufficient engagement and coordination between, I believe I said between health and non-health federal agencies. You know, no, I don't. I have to find it. Let me find it. You guys should keep going.
Yeah, I agree with dropping the word engagement. I think it really is coordination, and it does sound like people don't care. But insufficient coordination among health-related and non-health-related federal agencies that influence these conditions, I think would address the point.
The problem, Bill, is that the healthcare agencies do not influence the social and environmental conditions. It's the this really was about the non-health federal agencies, this particular sentence.
So what about insufficient engagement of the non-health agencies and insufficient coordination amongst all agencies, non-health and health?
Hi, Jennifer. I think I heard somebody. Good. Okay, yeah, I thought I heard somebody speak up. I just want to make sure they were able to speak.
Go ahead, Naomi.
Oh, sorry. I was saying that I think keeping the term insufficient is really addressing the real issue that we all face amongst all federal agencies. So to try to sort of make it seem less than it really is not really getting across the message. So I think insufficient engagement is good.
Right, so you want to leave it as it is, right?
Or I'm willing to go with what you've just rewritten there in terms of engagement of insufficient engagement and insufficient coordination. That makes it clear.
Okay.
Yeah, as long as the insufficient engagement is accompanied with the agencies that influence these conditions. Because
okay,
the health ones don't, yeah.
Of the non-health agencies that influence?
That influence these, yes, thank you.
Okay, conditions and insufficient coordination amongst all agencies, non-health and health. And then do we need anything rest of this sentence, or is it covered in this right here, this new sentence?
I assume you'd put federal agencies somewhere.
Yeah, it has to be federal. Mm-hmm.
This is Don. I had a comment on this, a brief comment. I think part of the consideration is
that the federal agencies are not tasked to engage, and so maybe there's been insufficient tasking to engage, because the federal agencies are going to engage in what they're required to engage in. But I think
Yeah.
it may be that they have not been required to engage in that. So I might add the word tasking at some point, or required to.
That's an excellent point.
So what if you said insufficient required engagement? Insufficient required engagement of the non-health federal agencies that influence these conditions, and insufficient coordination amongst all federal agencies, non-health and health. Does that help
Requirement.
clarify?
I keep the requirement so it flows, whichever way you word it, but I think it's an important point that we walk as we're tasked to do.
So this is Barbara. I mean, I think I'm just a little concerned that the sentence itself is becoming very unwieldy, because what we're editing now, it's hard for me to see, I think is just one in a series of 3 different clauses in this sentence.
Yeah, we have to break it up.
So what would be the preference to change this so that it represents what the agencies do, are required to do, and tasked to do?
Well, so instead of, I mean, Dean said to break it up, but another alternative, because I think, what if you take, the end of the sentence is like it's 1, 2, and 3 have all hindered national health efforts to prevent and treat diabetes. So you could start the sentence by saying, national efforts to prevent and treat diabetes have been hindered by, and then you could do like 1, 2, 3 or something like that. Right, because the sentence is that the socio-demographic factors, the coordination, and the persistent gaps in access to health care, those are the 3 things that have all hindered. Okay, if I'm understanding the sentence.
You are right, Barbara.
I'm sorry, did you want me to repeat what I said before?
Yes, I'm sorry. Can you repeat that so I can try to type that, what you said?
Okay, no problem. I was suggesting perhaps we start the sentence as efforts to prevent and treat diabetes have been hindered, or national efforts, I'm just reading from the sentence, so I'm sorry, national efforts to prevent and treat diabetes have been hindered by, and then you could go back to the beginning of the sentence. So you could say, 1, the socio-demographic factors that shape the conditions that people experience in their daily lives. 2, and then we can fix the wording of this engagement and coordination. And 3, persistent gaps in access to health care. So I've just rearranged the sentence.
So it would be failure to address socio-demographic factors.
I'm sorry, okay.
Right. Efforts to prevent and control diabetes have been hindered, or national efforts to prevent and control diabetes have been hindered by failure to address socio-demographic factors. Insufficient engagement and coordination, and persistent gaps in access to health care.
So unless we make 4, it's still quite a long number 2 if we keep what was listed above, I think, around insufficient required engagement. I mean, that's almost like a 2 and a 3.
I don't remember, I can't see the original wording before, but I think the original wording basically said it.
Yeah, the original wording actually said just
A lack
replace
of
that
coordination among federal agencies, period.
Right, and persistent gaps in access to health care have all impeded national efforts to prevent and control diabetes. Orders, the 3 move the access up. It might give us a little bit more flexibility because I think the point regarding tasking of the agencies to engage is significant. So what are you suggesting we change it to, Jana? Right, so I would suggest that to be national efforts to prevent and treat diabetes have been hindered by the failure to address, again, it's a little hard to read, socio-demographic factors that shape the conditions. And I'm so sorry, I need to expand my screen here. I'm having a really hard time reading that. Old eyes, I think. And then move the persistent gaps in healthcare. So the number 3 would become number 2. And then we can determine how to word the lack of engagement or perhaps need to task federal agencies to engage and coordinate efforts. Okay. Is there any opposition to changing? Go ahead, Jana. I'm sorry. And perhaps we can say directives for federal agencies to engage. So say that again so when you said instead of using insufficient, I'm rereading here. So lack of directives, and maybe this is for trans agency participation in these efforts. Trans agency engagement and coordination efforts? In these efforts, yes. It definitely open to anybody else's wordsmithing. Okay, does this, what Jana has suggested, does that get to the issue here for this paragraph and the sentence?
So the one concern I have, well, 2 concerns. One is the order. We want to retain the order as we have it in this chapter, which is number 2 should be the trans-agency work, and number 3 should be lack of access, persistent gaps. And then secondly, you don't really address demographic factors. A demographic factor is often a fixed characteristic of an individual, so it just feels a little bit off.
Would consider be a better word?
Well, I mean, I don't know that we've failed to consider them. I think it's failure to address the social determinants of health. It's not failure to address the socio-demographic factors.
Yeah, so that would be fine. Failure to address the social determinants of health, which are the socio-demographic factors that shape the condition.
Yeah, they are linked. They are associated with their higher risk in certain socio-demographic groups.
Yeah, so that can just be changed to failure to address social determinants of health, comma, and I agree the second point should be interagency coordination, and then the third access to care.
Okay, Dean, can you put that in the chat for me to pull it out?
I couldn't understand you, Jennifer.
So there is someone who doesn't have their mic muted and is on the phone line. If you can just mute. Can you go ahead and type that into the chat so I can pull it up and put it into the comments over here?
Okay, I'll as long as it's on the screen, I can do that.
I was just going to say, while he's doing that, you have number 3 as persistent gaps in healthcare is what's written over there. It should be access to healthcare. Just if that's what you're going to use to replace, I just want to make sure it's access. No, you had the persistent gaps was right. You just were missing the access piece. It would just, yeah, it would be persistent gaps and access too.
Okay, so this is, all right, so let me grab what Dean, failure to
Can you
address.
see it, Jennifer? Are you able to see it? Because I can't send it.
Yeah, I gotcha. I just
Okay.
put it into here. National effort to prevent, okay, failure to address SDOH, lack of directives for trans agency, and persistent gaps in access to health care. Is everyone in agreement that this is now what this paragraph or area is going to say?
Yes.
Is there
I
any
do, but it's
disagreement?
only that the last two sentences should now be the first two, because it's we've kind of flipped the logic here.
Right. Okay. Okay, is there any disagreement with this now?
I guess I'm still confused about what's the rest of the sentence for lack of directives for trans agency, because I'm not sure we've addressed the concern, which was that there is directives for trans agency collaboration, right, in federal agencies, but non-health federal agencies there are not. And so it's, I don't know, I'm not within those federal agencies that do trans agency collaboration, but I guess I would ask them to comment on that.
So it should be in lack of directives and insufficient trans-agency engagement and coordination, or some. It's not that there isn't some effort; it's that it's insufficient. So you're right. We need to clarify that. There are no directives for the most part for non-health, and then there are some directives within the health, right? So that's what we're trying to deal with.
What did you say, Dean? You said lack of directives for trans agency
engagement. Yeah.
Yep.
Actually, I think that's fine. And insufficient coordination. I think it's fine. I mean, Department of Transportation was very clear that they don't have a directive to work on diabetes prevention control for the reasons that Donald Schell mentioned. They've not been tasked to do it.
Okay, so then if we said that, then it would be lack of directives for trans-agency engagement of the non-health federal agencies that influence these conditions and insufficient coordination amongst all federal agencies, non-health and health. And then go on to persistent gaps in the access to care.
Yeah, I think it was Sherry who raised the concern. I don't know, Sherry, if you still have that concern, sir.
No, this is fine. I just think it was shortened, so I didn't know what we were saying at the end. So I think now it's clear.
Okay, so is there any agreement to what this new sentence says and how this paragraph is going to now flow?
So are you going to flip the last two sentences up?
Yeah, I just put the note here, flip last two.
Okay. Okay, thank you.
Okay. Yep. Okay, so that would resolve this area now. So if we scroll down, so there's been a couple of comments. Dean and Bill, you both mentioned that the model is too small, so we would try to get a bigger version into the report to be more readable, okay? And then that would be the last comment / change that we have, unless there are other comments for this chapter 1 background.
So it doesn't sound like there are any others, so let's move on.
Okay, so is there a motion?
Motion to approve the revisions.
To approve the revisions and the chapter.
I second that motion.
All in favor say aye. Aye.
Aye.
Aye.
Opposed, say nay. Okay, let's go on to the next chapter, which would be chapter 2, methods. We are really getting bogged down and we're running behind schedule, so we're going to need to pick it up.
Bill, this is Paul Conlon. May I make a comment about that?
Yes.
This last exercise illustrated that we're basically doing real-time editing among 23 people. And that's going to, we're going to end up much longer than we're allotted. One proposal for consideration is to, assuming the individual who provided comment could be queried as to what their concerns were, and maybe the threshold for making edits would be how critical is it for them to accept the report with or without their proposed changes, and therefore we can get an idea of whether or not these are suggestions or really critical to the overall vote for the report. And that way we can focus our attention on those that require most energy as opposed to those that might be wordsmithing nice but not essential.
I like that suggestion, and actually also think we should probably focus on the recommendations more than the background language.
Well, the only problem you have is that there are some that don't agree with the background, and so that would need to be resolved. So to let you know, in this section this is chapter 2, the methods, and there is one comment about adding another paragraph in here about the work process, and then obviously we would update this, but otherwise that's the only 2 items in this methods section.
Jennifer, Paul Conlon here again. I acknowledge that there are lots of different comments, but the people who offered them would probably be in a better position of knowing, are these really critical to their accepting the overall report, or would they be nice to have? Only because ultimately at the end of today's meeting we have to have a yes or no vote. We don't have the luxury of time of going back and scripting new paragraphs, etc. So I think it would be really important for us to know how high is their concern.
And I don't think you'll know until we get to those chapters.
Yeah, no, I agree. But I think that what we should do is try to avoid going over every single one unless really there's a driver for that to be essential for the acceptance of the report.
So Paul, are you asking that Jennifer asks for each edit if this is essential before discussing it?
What I was proposing, Cara, is that these originated from individuals, presumably most if not all are on the call. So that person who raised the question could be queried, how critical is this to us, to your accepting of the report, and does it absolutely need to be modified?
Hi, this is Barry Marks. I'm just concerned that that's going to cause us to lose the kind of discussion and deliberation that's going to produce the best product. Over.
So Barry, my comment doesn't come from the perspective of trying to stifle dialogue, but reflecting the fact that we're basically at the end of a very long process, and time is short for us to be doing real-time editing, and therefore, there are many elements of the report that we might like to see a little bit different, but time doesn't allow us to go through and edit every section with every person's comments today, this afternoon. So I'm trying to look for a way that we could respect people's interest in dialogue, but not necessarily get bogged down in rewriting sections and the time that's going to require.
Paul, this is Dean. I'd like to make a slight compliment to your proposal that I think might also accommodate Barry's concern, which is I think the individual or individuals who wrote the section that the critique is responding to could also, irrespective of whether it is a critical fix or a nice fix, to say like, yeah, that's an easy fix. Like, I could take care of that. Don't worry. So that we could accomplish both very quickly. I agree with you. Wordsmithing would be impossible.
So others can comment on how we can move forward. Obviously, the intent is to be expeditious, but thorough, and certainly not in any way to prevent people from voicing strong opinions, but also recognizing the fact that we're short of time, and there's already been a lot of work that's gone into the report to this point.
So Paul, I just want to make sure so Paul, I just want to make sure that everybody understands. So when Jennifer moves on to each point, if it's a minor copy editing point or just a minor wordsmithing point, you want that person to be asked if there needs to be deliberation on this, or is it not a substantial need to change it?
That was my proposal, Cara. Others can comment on it. The reason I say that is some of the comments might merely be changing of words, and as we just saw in the last section, a sentence took us over half an hour to resolve.
I'm in support of your proposal, Paul.
So Jennifer will go to each point and she will ask, but we need to make sure that there is room for discussion for substantive changes and that people are able to voice their concerns and their desires for change.
Yes, I think that summarizes it. So substantive changes only. I think given I would agree with Paul, the fact that so much work has already gone into getting us to this point.
But Barry, if there are many points, to bring them up.
Great. Jennifer, your thoughts on that going forward?
Yeah, we can try as long as there's discussion and people get to provide comment and that they're not dismissed. So again, in this chapter 2, you get the message. Again, there was a proposal by Dean to add a paragraph in here about the writing process. And then obviously we would update this based on today's vote. So this one doesn't need to be, we'll update this. So the question is to add the paragraph that Dean suggested about the writing.
I think that's been reviewed through the email, Jennifer. Is that correct?
Okay. So then is there a motion for this method then? Then there'd be nothing to cover.
Well, I would say it hasn't been reviewed via email. You responded, Kara, that you were not in favor of that. I will not hold up this meeting to fight this dragon, so I'm happy to let it drop.
So that is dropped, Jennifer.
Okay, so is there a motion to accept the chapter?
Yeah, motion to accept.
Was that Bill Chong? I'm sorry.
Yeah.
John Boltry, second. All in favor, please say aye.
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 Aye. And opposed, say nay. All right. Chapter 3.
Okay, so for chapter 3, we keep going. So, Bill, this is, again, revised wording. You had expressed that you wanted the original. Naomi wanted the original. So did David and Jana. So do we want to revert back to the original wording? Is this a no-go?
I thought that the original was clearer.
So you thought that, so did Naomi and David and Jana. So they agreed with the original wording.
I also agree with the original wording. This is Dean. I also agree with the original wording.
Okay.
So I move to keep the original wording.
Was that you, Naomi?
Yes, it was.
Okay, thank
And
you.
a second?
Was that you, Bill, that second?
Sure.
Okay.
And all in favor, say aye.
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 Aye. And opposed?
Aye.
Opposed, say nay. All right.
Fantastic.
Let's
So
move
we
on,
will
Jennifer.
get back to the original wording. Okay. So Dean, you had made a style recommendation, which is fine. And then you had a change for the word develops. I don't think that's a big change. Are you good with that?
Yeah, I'm good with making that change. It was a grammatical error.
Yep, there we go. So the next thing, so there is a change here. Barbara says that the sentence didn't make change. She thought that there was something missing. Barbara, is this a no-go or a revision, or are you good with leaving it as is?
I'm sorry, where are we now?
You have, yeah, the word cost related in the last sentence is incorrect. It should just say higher non-adherence. This is a grammatical problem.
Okay.
This is Carol. I think you could say non-adherence due to cost of medications and or services has been reported to occur in 20% to 40% of people with diabetes. And something like for those with self-reported financial insecurity, non-adherence is higher at around 60% or something. But I think defining, instead of cost-related non-adherence, non-adherence related to cost of medications and or services might clarify some of that.
It seems like it's the second part of this sentence, actually. What is it trying to say? self-reported financial security
No,
is associated with 60%.
It's saying that cost-related non-adherence is common, and that among those with financial insecurity, I presume, yeah, I mean, it's not clear. It's that non-adherence is 60% higher.
Yeah, this is Bill Chung. I think the way Carol phrased it seems to help clarify that the statistics are two different pieces of information that, as a general matter, non-adherence has been reported to be related to cost in 20 to 4% of people, and those people self-report financial security, it's even higher. So I think the way Carol phrased it makes it clear, and I think hopefully that addresses the grammatical issue that Barbara flagged.
Yeah, I mean, when Carol said it, it made sense to me. I just wasn't really sure what the sentence was trying to say because it's not grammatically correct, but what Carol said made sense.
Yes,
All right,
I agree with Carol's edits. I think that helps.
All right, so Carol, can you just put that in the chat and I'll add it to the box here, okay?
Okay, thank you.
So it seems like everyone agreed, or it sounds like there is agreement for Carol's verbiage, okay? So we'll add that once she puts it into the chat, all right? Any disagreement with that? No? Okay.
Carol, you mentioned services and medications. Do these studies actually, what are they referring to in reference 56?
I can try to look it up. I know medication was in there for sure. I can just say.
So I wouldn't elaborate unless we know that that's what the article was about. Yeah.
Cost has been reported. That sound better?
Also, cost-related non-adherence has been reported to occur in 20 to 40% of people with diabetes and up to 60% of people with self-reported financial insecurity, if that's what the study said.
Do people have...
So Bill, are you saying you don't agree with her edits?
I don't see her edit, so but it was, she had said something about services and or medications, and I just don't, it seems like we're adding something to what was here.
Is cost-related non-adherence clear as opposed to non-adherence due to cost?
Yeah, I think so.
Yeah, I think we're getting into wordsmithing territory here, guys.
Right.
Yeah.
Okay.
Right. So again, if you can just send me what you had, Carol, I can add it here since there's to be some agreement, okay? Perhaps not with services, but with the other verbiage that you used, okay?
Okay, thanks.
Thank you. Okay. And then we'll go down to the next one. So there were a couple of different, there's a couple of different, so the first one is that, Bill, you had suggested adding for people at risk with diabetes at the end of this sentence.
What are you looking at? Where are you?
This one right here, 3A. So you had suggested adding for people at risk with diabetes at the end of this sentence. And then you also had a different, and then you also recommended revising that verbiage to say federal agencies consider and evaluate the impact on health disparities of all new, all revised, and selected existing policies and programs that affect diabetes prevention, diabetes, and the complications of them. Of diabetes.
So diabetes prevention, diabetes, and the complications of diabetes, yeah. So this is a more general issue of prediabetes as a disease rather than as a risk state. And so if we're talking about diabetes prevention, I don't think we need to call out prediabetes as a disease.
So I think the question would be is, do you all agree with the revised wording that Bill suggested? It's the second one. I know Jana said that she agreed with Bill's second suggested revision. So again, it would read, federal agencies consider and evaluate the impact on health disparities of all new, all revised, and selected existing policies and programs that affect diabetes prevention, diabetes, and the complication of diabetes. Is there any
complications.
Okay. Is there any disagreement with making the change to Bill's new verbiage?
Okay, let's move on.
All right. And then, what is this one? Oh, no. Okay. And then that is the end of chapter 3. So is there a motion to accept the chapter with the...
John Boltry, motion to accept the chapter.
Carol, second.
All in favor, please say aye. Aye.
Aye.
Aye.
Aye.
Aye.
Aye.
And opposed, say nay. All right. Chapter 4.
So Pat had she wanted to be know that CDC actively support. So does this mean you want the sentence changed, Pat? Or is this fine
No,
as it is?
this is it's a minor comment. I would like to see CDC mentioned here if others agree. This is a big part of our mission and where we've invested over the past few years.
So what we could do is where we talk about the American Diabetes Association and National Academy, we could add CDC after NIH.
Exactly. That's what I was proposing.
Okay, fantastic.
Thank you.
Is there any opposition to that? No opposition? Fantastic. We'll move to the next one. Barbara, that's just a copy edit.
That's a copy. It's a grammatical error. Yeah.
Okay, so then Bill recommended that this be rewritten to, this could be accomplished through a combination of federal incentives and possibly tying receipt of funding for school-based food programs to access to drinking water in the future.
It was more of a clarification. And I think that was the intent, right? So federal incentives and tying receipt of funding for school-based programs to drinking water.
Well, I don't think it's necessary, Bill, because that's what the sentence before is about. The "this could be accomplished" is reliable access to safe, appealing, and free drinking water.
Okay, I removed my concern. Let's go on.
Okay, so no action. Okay, thank you. We'll go to the next one. Okay, these are just some grammatical edits. Okay, so there are a couple of here. So Bill, so this was a revision based on what Dean put together to OWH's comments and suggestions. Bill wanted the original language. Naomi preferred the original, as well as David and Jana. So I guess the question is do you want to go back to the original verbiage, which is here? It says, in this context, it is notable that the U.S. government has not issued scientific reports or guidance to the public about the health hazards of sugar-sweetened beverage consumption. This has undermined the ability of clinicians to effectively guide their patients in the prevention and treatment of diabetes. In addition, federal agencies largely fail to call out sugar-sweetened beverages as a health hazard, and their public communications recommendations to reduce or eliminate sugar-sweetened beverages from the daily diet are absent from even the CDC's National Diabetes Prevention Program curriculum.
Yeah,
So the
and this
question
is
is-
Pat. I did have a comment about the reference to the National DPP curriculum. We have revised that curriculum. We've gone through the past year and a half with a panel of nutrition experts revising Prevent T2, and that is due to be released here at the end of the month. And it does, revised curriculum does address a number of the nutrition components in the curriculum, including mention of water intake.
So, Pat, this is Dean. I'm excited to hear that. I think that our subcommittee needs to see that revision, because right now the statement actually is accurate that the National DPP curriculum does not have recommendations to limit sugar-sweetened beverage intake. I'm not talking about water here in this last sentence. Are you able to share bullet points from that curriculum? But because in the absence of that, I don't see how this statement is inaccurate.
And
Yeah,
I think it's not
the problem
so much
there,
pointing
Dean,
the
is-
finger.
Yeah, I
don't
was
think
just
it's so
going to
much
say that
pointing
the
the finger
issue,
at CDC. Go ahead.
yeah, none taken. I just want to be clear that we have a curriculum that is completed that does address sugar-sweetened beverages. I can't, it isn't released to the public yet, but it's only a couple of weeks away. I could look through the entire, it's woven throughout the curriculum in various places. So I would need to go back and look for that language if I were to send you all bullets. But it is there, is what I'm saying.
Well, I will just share
I think the
that.
general point.
Go ahead, Bill.
Go ahead. I think the general point we are trying to make is that sugar-sweetened beverages have not been on the radar screen as much as they should be. And I think it's great that it's now.
Pat, I agree with that point. I just would encourage us to be really clear and specific. If we're going to call out a specific curriculum that doesn't mention it, when in fact we have revised it to mention it, I think that's a little bit misleading.
How about, Pat, would you be comfortable with
recommendations?
Would you be comfortable with it saying recommendations have been absent from the CDC's National DPP curriculum?
Or until recently, recommendations to reduce or eliminate were
until
absent.
recently, yeah, I agree with until recently.
Okay, but I just want to say that in the past, I've communicated with the CDC, and they've told me that their DPP curriculum does have content about reducing sugar-sweetened beverages, and when I've reviewed that content with the CDC, they then say, oh, yeah, you're right, we actually don't say it. So I think we need to see the language, and it's a quick word search. It doesn't take long.
Yeah, I am looking at it, Dean, so it is here. But, again, I think we can debate this. I just would encourage us not to be misleading in calling out a specific program.
Well, it's a very specific program for a reason. It's the National Diabetes Prevention Program. And for 20 years, it hasn't recommended anything about sugar-sweetened beverages. So it is not an insignificant and random program to specify.
So Pat, you would be okay. So you would be okay if we added until recently in front of recommendations to reduce or eliminate, correct?
Yes.
Okay.
And change
So
are to were.
Yes. Okay.
Well, I'm not comfortable with that until we see the actual curriculum. It doesn't, there's a very, very subtle way in which sugar-sweetened beverages are carefully communicated around in the CDC, in the history of the CDC communications, and there's a reason for that, which we can get into. So I think it's just important that we see the actual language. And if the language is there, this makes total sense.
Hi, Pat. This is Kara. So you're saying that the curriculum is still being developed and then it'll be cleared. So you probably can't share any of the text or content, right? But you know that what you are saying is true and that it should be until recently, right? Is that what you're saying?
Yeah, that's essentially what I'm saying. The curriculum is done. The development is done. It's just going through its final stages of release to the public.
But Kara, there are a number of policies that are in revision, including at the USDA, that we have decided we will continue to call out until we actually see that policy that's being discussed and planned executed. We have not censored our recommendations based on what we believe the future holds.
And I guess if it hasn't been cleared, we don't know that it will be cleared.
Right.
That's exactly correct.
It's noted that
It has, can I just,
report date.
yeah, if I can just correct that statement, it has been cleared through the CDC process. It just has not yet been released to the public.
So to me, I agree, Kara, that if it's embargoed, we can't see it. But I do think, Pat, if you can summarize for us based on your review what the statements sound like, I think that's not embargoed information.
Yeah, this is Don. I think she probably can't edit all the language, but I think maybe something to the fact that it's come to the committee's attention that by the time this report is released, the CDC is expected to have, the DPP program is expected to have updated its, language regarding sugar-sweetened beverages. Because by the time
so Donald,
it's going to be.
I really think until this information is in public domain so that everybody can see it and review it individually or independently, I think what we have here is accurate, and it should stand the way it is.
I agree. This is Bill Cook. I agree with Iaconde. Suppose there are some recommendations and we at the end of the day don't think they go far enough, then I don't feel like we've called this out appropriately. This is really an important program that we use on the ground in a big way.
This is Bill Chong. I know, Dean, you said in the national DPP curriculum there was nothing about sugar-sweetened beverages, sugar drinks. I was looking through what everyone's talking. There are a few statements in there that touch on this. So I think that the piece of saying they're absent is maybe incorrect. I think there's in one of the modules talking about healthy eating, it says drink water instead of sugar beverages. On diet, they talk about limiting.
No, it doesn't say that, Bill. There is no.
It does.
No, Bill, it does not say that. There is no mention of the word beverage in the entire DPP curriculum. There is mention of what you should drink.
There's a statement that says drink water instead of sugary drinks. It doesn't say beverage, but it says drinks.
Drink water instead of sugary drinks. Okay. Perhaps. The rest of the DPP curriculum, including the chapters, the modules for patients on healthy eating, calorie counting, and one other chapter that's relevant, simply avoid the word sugar except when they talk about putting sugar in tea or coffee.
So I think my point is that the statement about being abstinent is maybe incorrect in that it's not emphasized.
I will look up
that might be a compromise there in using the language that was just suggested, emphasized as opposed to absent.
So recommendations to reduce or eliminate are not emphasized in the CDC's curriculum?
Yeah, I'd appreciate your thoughts on that language.
So Pat, would you be okay? And what about Dean? Would you guys be okay in changing emphasize from, to change absent to emphasize instead?
So not emphasized in the CDCs.
Mm-hmm.
What do you think?
Does that allay your concerns, Pat?
No, not fully, but I understand
right.
we can't debate this indefinitely here. I will, perhaps another compromise is, I cannot do it as we speak, but let me go back to the modules this evening. I can pull some sample language and just bullets and send them in an email if that would help. Because again, I think there's interpretation here, even with the word emphasized, and what that means to different people.
Yeah, the other option, the other option, Pat, is Donald's recommendation, which would be to say recommendations to reduce blah 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 have been absent. However, the curriculum is being revised and is expected to include such guidance.
I think that's great. I think that's great. That is a nice compromise.
Okay, so we'll use Don Shell's verbiage.
I just want to add one more thing. Instead of absent, could we still add not emphasize? Is that because that was somebody else's point as well? So should we consider both points?
Yeah, Kara, if you go to the dietary module of the DPP, there is extensive language about what to eat and not to eat, and sugar-sweetened beverages are not mentioned at all. There is maybe in the overview that Bill was referring to the words of drink water instead of sugary drinks. This is a hundreds of thousands of word curriculum. And I believe that is the only time, if that's true, that it appears. But in all of the relevant modules, which are the classroom modules, it is absent.
Yeah, Dean, I just wanted to make sure that somebody's comment wasn't dismissed without being acknowledged.
Okay, so we're going to make the change for the last sentence. However, the previous sentences, this question still remains to leave it as it is or to go to the original verbiage except for the last sentence.
Let me just I want to address Bill Chong's concern, which is appropriate, which is I would say are largely absent. I would say largely absent.
That works for me. That works for Pat.
So what is the current revision?
I think that the sentence would now read recommendations to reduce or eliminate sugar-sweetened beverages from the daily diet are largely absent in CDC's national DPP curriculum, and then there's going to be an addition of something about, in the upcoming update or something like that.
Right,
I don't
we're going to
remember
get
Don's verbiage.
Right, we're going to get his verbiage off the transcript.
Okay, that's fine. I think with the addition of Don Shell's sentence, that would be okay.
Yeah, and I would also make it be have been absent, so it's in the past.
Agree.
Or have been largely absent, sorry.
Have been largely absent, yeah.
Yeah, have largely been absent. Thank you, Pat and Bill. And Don.
Okay, so now, and then we still have to address the original three sentences up here. So do you want to leave it as is or go back to the original? Again, we have three that want to go back to the original.
I will say, this is Dean, having been involved in the revision. I appreciate the concern that perhaps the original language felt inflammatory. I feel that the rewrite retains the intent and content the new language retains the intent and content of the old without being perhaps as inflammatory. So I am comfortable with the revision, which is what is in yellow here, for whatever it's worth.
Okay, so Bill, Naomi, and Jana, are you okay with leaving it then as it is, under the revision in the yellow?
Yes, I am.
This is Jana.
Naomi? Yeah, Jana, go ahead.
I am as well.
Thank you. How about you, Naomi?
Yes, that's fine.
Okay, are there any other disputes, or are we good, everyone is good to move forward?
Let's move forward.
Okay, so this is just, is that it should, so Pat, were you asking for a change in this wording? Because Dean was going to have CDC, NIDDK, and USDA to the beginning of this, but Pat, was there additional change you wanted?
I think Pat had this right through.
I think the issue here goes back to our earlier discussion about unfunded mandates. That, you know, when we're talking about a national campaign, that's very expensive. Without additional funding, at least for CDC, that would be difficult to absorb with our current work.
Yeah, I mean, I think that's true of all agencies.
That's true of all recommendations.
So Pat and Barbara, what would you want to have change, or are you okay with leaving it as is?
I think it would be helpful to insert the phrase as we have in other places with additional funding, CDC
Yes.
and NIDDK.
Okay, so you want to add
CDC.
after. Right. It's going to be CDC, NIDDK, and USDA with additional funding, right?
Or with additional funding, comma, CDC, NIDDK, and USDA.
And can it be NIH instead of NIDDK?
Correct,
Yes,
yeah.
I switched it to NIH and USDA in response to comments, so I agree.
Thank you.
Okay, so it'll say with additional funding, CDC, NIH, and USDA should. Okay? Any disagreement with that? All right. So we have a couple of comments. This, again, was changed. Bill liked the original wording. Naomi likes what it is now. So does David and Jana. And then Bill Chong, you had a comment about this.
Yeah, so first I wanted to apologize. I didn't think to seek some feedback on this piece of the report with my colleagues in the Food Center, but these is more, the comments I added are more sort of informational for the subcommittee. I don't know if any of them necessarily change things, but a few of them are around not really being sure where the statements come from in terms of if there's a reference that could be added, and some are just highlighting some things that some other bits of information that may be relevant to some of the language and recommendations. So for this one, it was more it would be helpful to see. We think it might be helpful to have a reference in support of that statement, and then just a piece that FDA looked at food labeling primarily as a general population, not so much for specific diseases, but that's it's more informational for consideration of whether or not the subcommittee and writing group for this section felt like they needed to or wanted to make any edits.
Thank you, Bill. I will say that we had extensive references, but we were given guidance to try to limit our references. So all of the statements made have associated references that could be added in. This is particularly true around the toddler milk issue, where references 149 and 150 are comprehensive for the entire paragraph. But if you believe that additional references are needed, and if there is a process to do that, we could provide it. So it's a question of how critical, I guess, you think it is.
Yeah, I think it's helpful clarification on the toddler milk piece. I don't know that we necessarily recognize that 149, 150 kind of reached that far back, but I think that's fine. And I don't know that we necessarily feel strongly that we need to include an additional reference in that last sentence. We similarly got guidance when we were writing our section that we should try to be judicious in citing references.
So I guess I'm hearing that you're okay with not having a reference up here for the revised sentence. It looks like Jana, David, and Naomi like the change. Bill, are you okay with leaving the revised sentence in yellow as is instead of reverting back to the original?
Yes, I like the change. That's fine.
Okay, so we will keep those. Okay, and then, so I guess the question is Dean, did you want to put in an additional about the toddler milk, or Bill, are you okay with the two references that are already here?
I haven't reviewed them, but if Dean says that they are relevant to the toddler milk piece as well, I think that's probably adequate.
Okay.
Yes, and they reflect the yes, they reflect the content that was presented by the key informant, who is an expert in the field. So yes, they more than adequately support the statements made.
Okay. Are there any other issues that you have? I know you made 3 comments, Bill. Are there any other, Bill Chong, is there any other issues to address here, or are you okay to move forward?
I can just share quickly the two, the sort of the intent behind a couple. One is just kind of to highlight that with regards to that piece about the prohibiting certain terms, just that First Amendment rights and issues sometimes do crop up in that sort of space, but I think that's just commentary for information. And then the other one is just kind of pointing to that there's some regulations that FDA currently has in terms of scientific evidence for health claims. And again, that's more informational. I don't know that necessitates any changes to the language.
Okay, so if you're okay with that, then we're going to go to the next one, which again is your comment about the label. So are you asking for changes, or are you okay with how it's written and you're just providing information?
So both of these are more informational for whether or not the group who wrote these recommendations think any additional changes need to be made or not. The first comment here is just to note that there was previous consideration around the use of teaspoon, tablespoon units in terms of the nutritional labeling. And so it provides some context there. And the takeaway was that it was felt at the time, I think this was in 2012 or so, that the additional information would be difficult given that it's a volumetric measure rather than a weight measure, and different types of sugars or different types of things have different densities, and that complicates things. And then additionally, that there's an issue with a degree of accuracy. So that's more informational. I don't think that I'll leave it to the writers of this recommendation if they think that additional information is relevant or not, or necessitates any additional thinking or changes here. And then 4.5C was just to make for awareness that there was I think in March last year is what they told me, that there was some informational awareness campaign on the added sugar piece of labeling. So those are just more informational. I didn't have specific recommendations on making the changes, making any changes here, but just to share that additional information for context, and if that's helpful and for others to think about on these recommendations.
Yeah, Bill, this is Dean. I really appreciate the comments. The first one is absolutely true, that there was a lot of public comment provided to the FDA around including teaspoon units, and there was a long scientific discussion about the pros and cons of doing that. Subsequent to that 2012 meeting, there's been a lot of research showing how Americans do not understand the grams unit that the added sugars are trying to communicate on the nutrition label, and so there has been a significant amount of both academic and advocacy work to try to revisit this question. So the intent of this is to have the FDA revisit that. The second point I think is very important around the multilingual communication campaign, because we spoke to the FDA individuals in charge of this issue, and they were very clear that yes, they are doing a multilingual communication campaign, but it is not robust. And they need more funding, getting back to Pat's point, to do it well, and that they acknowledge that they have been unable to do it well, and would be excited by a recommendation to enable them to do it better. So I think there may be an opportunity to tweak this 4.5C to communicate that better. That's why the language of robust was included. It was actually the language from their presentation to us.
Certainly. So, I mean, I think on 4.5b, if there's been new thinking or new information, certainly it's worth revisiting that. So I don't have any issues with that recommendation. And I think I think you raised some good points on 4.5c about sort of funding, and I think it's kind of ties back to something that has been commented about, sort of unfunded mandates and things and that sort of thing. So I don't know if I don't have any initial thoughts on if there's additional tweaks to the language that might make that clearer, or if the inclusion
Could we do the same
allows.
Could we do the same thing that we just did with CDC, NIDDK, NIH, and USDA around with additional funding FDA should implement?
I would be in favor of that if that's the issue.
That sounds like it would work if that was the issue that was raised by the folks in the Center for Foods.
Yeah, they couldn't raise it explicitly that way. Obviously, they cannot request more funding, but it was clear that resources would need to be brought to bear, is I think the language that was used.
Okay, so for 4.5C, then we would add with additional funding, FDA should da-da-da-da-da. So that would satisfy Bill Chung's concern and then also add funding to the communication campaign. Is there any disagreement with that?
This is Paul Conlon, Jennifer. Adding that line to that specific recommendation is specifically focused, whereas it seems like every recommendation here is likely going to be otherwise viewed as an unfunded mandate. And I dare say, as Dean pointed out earlier, if we add that to every recommendation as we go, basically every one of the recommendations is going to say with increased funding. So either we have to be judicious or put it in every recommendation.
Or it could go up under 4.5. The National Clinical Care Commission recommends that the USDA or that the FDA receive additional funding to improve its food and beverage labeling regulations.
Yeah. If you're going to include it in this recommendation, it should be up above.
Well, but that just kicks the can higher, Paul, no? Then every recommendation
would apply to 4.5 A, B, C, and D.
But why doesn't it apply to 3.4 or 6.4?
So that was my point, Dean.
Yeah, exactly.
Yeah.
Well, maybe it's implicit.
I think it's implicit. I do think it's implicit in all of these recommendations. Some cost money, some are more internal regulatory things, but I happen to agree with Paul.
Okay, so we're not going to make that change.
So I want to be respectful of the fact that we all, speaking from the federal sector, we all face this issue of unfunded mandates, some more than others. But if in fact we're going to call it out, we'd have to call it out for basically every recommendation. Otherwise, it's going to have to be implicit, and we'll have to defer to Congress that they feel it can be done on existing budgets or it needs additional plus-up.
Yeah.
Okay. So we won't make any changes here. We'll agree that it's implicit. So the next one, that is just a copy edit. And then the title should be the focus area, so I think that's just a copy edit. Would you agree, Dean?
Yes, it didn't make sense as is. That's like our entire report, prevent today.
Yeah, and so Bill says that there's no recommendation 1C, so we'll have to, do you know what this was referring back to, Dean?
Yes, it's referring to Carol's SNAP paragraph, which I don't remember what recommendation it is, 4.1, something like that.
Okay.
Where she outlined how food insecurity is a problem. Yeah.
Got it.
Yeah, Dean,
Okay.
when I originally wrote this is Bill Cook, the 1 and the C may have switched around a little bit. There's a decent addressing of this by the Healthy People 2020 report, where they run through a whole talk about housing instability that we can use. This, I think, was mainly I was putting this in as a reference.
Yeah, this is an internal reference to another part of our report.
Okay, yeah. In case that doesn't work out, though, there is something that goes over this fairly thoroughly in Healthy People 2020, probably that was used to define the 1C one.
Okay, no problem. So Bill or Barbara, these are just copy edits, so we're not going to cover.
Yeah, copy edits. Yeah.
Yep, and you already sent me that photo, so that's fine. Let's see. So there is a clarifying question that Bill had. Collaboration with other agencies should be clarified as collaboration with other federal agencies. So you just wanted to add federal, is that what I'm reading, Bill?
Yep. Yes.
Okay, fantastic. Okay, so that's the end of chapter 4. Were there any other comments that we did not cover, or are you ready for a motion?
Okay, I will accept the motion.
Motion to accept Chapter 4 with revision.
And chapter revision. Was that you, Bill? Herman or Tom?
This is Bill Chong. Motion to accept chapter and chapter revision.
Second.
All in
Okay,
favor,
so
please say aye.
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 And opposed, please say nay. All right. We're up.
You want to take a break, Bill?
Yeah, let's take a 5-minute break. So let's reconvene at 3:15, 7-minute break.
Okay.
Okay, 7 minutes. We'll be back. Thanks. All right, I think we're ready to get started again.
Jennifer, do you want me to call roll even though it was a short break?
In the interest of time, perhaps we can just continue.
Okay, we will continue.
Good. So Jennifer, chapter 5.
Yeah, so we have for chapter 5, the first comment is yours, Bill, about pre-diabetes is not a clinical entity but a state of increased risk, and that it needs to be explicitly addressed at the beginning of the chapter. So I guess the question would be, I believe you have something here. You said at the beginning of the background you would want to say addresses diabetes prevention in persons at high risk of developing diabetes, especially those with pre-diabetes, a state associated with an increased risk of type 2 diabetes and cardiovascular disease. And then in the second paragraph, you would make it say pre-diabetes is a metabolic state, not a disorder. And then the last paragraph, persons with pre-diabetes are at higher risk. So I guess the question would be, are there any opposition to making these changes as Bill has suggested for the paragraph?
And I would defer
Okay.
to John on this. There was a recent article in JAMA Internal Medicine emphasizing the point that we really shouldn't be calling prediabetes a disease, but a state of increased risk. And I think if we make these 3 changes in the introductory paragraph, we really don't need to change much more in the chapter.
Okay, John Boltry, do you agree?
I don't have a problem with the change, but I really think we need to ask Howard, and I know he's not here today. Do we have to make that final decision now?
I'm actually happy to defer to Howard, so let's let him make the decision, but I'll agree with whatever he says.
Yeah, and I agree with Bill's suggestion.
Okay. Okay, we'll make that note in here then. Okay, so then the next, so this is Pat, and she would like the paragraph to say the DPP and subsequent translation studies serve as. Are there any opposition to her revised statement?
I think that sounds fine.
Sounds okay to me, John Boltry.
Okay. Okay,
The
I
other,
don't hear
this is
any.
Pat, the other part of that comment I just wanted to mention, it's one program, so it should say provides a high quality lifestyle change program.
Okay. I don't hear any opposition to your change.
Pat, one quick question. Pat, wasn't there the national DPP and the Medicare DPP? Are those, they are different, right? So didn't they both come out of that?
But here we're talking about the national DPP specifically, and in terms of the program itself, it's the same program used by the MDPP.
Okay.
Okay, so John, are you okay to leave it to make this change?
Yes.
Okay. Is there any disagreement? Okay, not hearing any. We'll go to the next one. That is a copy edit from Howard and a copy edit. Just Bill made a note that he want to change diagnostic. Oh, yeah, it's changed. Okay, sorry, it's a copy edit. Okay, so then you, Pat, you had a comment because of the new guidelines, and then so did Bill. So I think this 40 just needs to say 35, is that correct, or 35 to 70?
Yeah, I don't think we can change the AMA proposal, but I think we should probably put an asterisk saying that the USPSTF has now recommended screening for 35 to 70.
Yeah, this is Pat, I agree.
Okay, so we would just have an asterisk with that statement, right?
Yeah, it would actually be okay after that first bullet.
Okay. Is there any disagreement with the change? Okay, not hearing any. So this was, so Bill, you had suggested replacing 4 prediabetes with diabetes prevention. Naomi, Howard, and go ahead.
Yeah, no, so again, this is for prediabetes. It suggests a drug for a disease. It's really more a drug for disease prevention. So that's the thinking there.
Okay, so is there...
So support metformin used for diabetes prevention rather than for prediabetes.
Gotcha.
I'm okay with that.
Okay. Any disagreement? No? Okay. And you just have a word preference. So Bill, you said that there should be something clarified that the data to be summarized is from the DPP study.
Correct. Yeah. And that is the intent, I think, Barbara. So we refer to the DPP study versus the national DPP or the Medicare DPP. I just want to make it clear that we're talking about the data from the study and its long-term follow-up.
I got it. So just adding study behind this would do that, correct?
Correct.
Okay.
Yes, I agree with that, John Boltry.
Okay, fantastic. Okay, there are a couple of comments here. Bill, you said that it should be clarified that coverage should be for people with prediabetes and BMI greater than or equal to 25.
Well, so John, the recommendation is that that all private insurers be required to cover participation in the National Diabetes Prevention Program, but it's really for people who meet eligibility criteria, right? Maybe that's implicit, but...
Right, yeah, that's correct.
And that might be, this is Pat, that might be a better way to say it because there are several eligibility requirements.
For those, how about just add for those who are eligible?
I think that makes sense.
That would
agree.
Do it for me.
Okay, so where would we add for, where would we add that?
So at the end of that sentence, CDC recognized diabetes prevention program for those who are eligible.
For those that are eligible.
For those who are eligible.
Okay. And then you had also mentioned, Bill, adding by individuals with prediabetes at the end of that recommendation as well. Did you want to do that, or did you want to leave it with what we just edited?
No, I think I just commented twice and thought differently, so what we just did was fine.
Okay, fantastic. We'll move on. Okay, so Pat, you had a request to update the number of states. Do you have that? Is it greater than 18, or do you have that number?
No, yes, it's 16. It's gone down.
Okay. Okay. Change 18 to 16. Okay. Okay, well, I'm sorry. We'll make that change. This is Howard's style. Okay, so Barry, did you want to talk about your comments here for Focus Area 12?
Yes, I'm happy to, and forgive me. Yeah, so actually that's not, I don't think that's where my comment was. It was a little bit further on in this section where we speak about identifying individuals at greater risk of progression. So I think you need to scroll down. There we go. And so, so it's the sentence, more research is needed to better identify people with prediabetes who are at high risk of developing type 2 diabetes and diabetes complications. And my recommendation was that we include as a reference the recent CDC study on hemoglobin A1C in populations of African descent. And my rationale for that is that we're at a point where we're increasingly aware of the potential and actual harm of embedded bias within tools that we use for diagnosis, treatment, and allocation of resources. And I think that the CDC in their paper identify this area as an area that very much is in need of research. And so I think that at the very least, it would make sense for us to include that as a reference and or add some text taken directly from the paper that specifically speak to the research need. But I think at the very least, I would ask that it be included among our references. Over.
Barry, do you have some draft language if you wanted to expand it, or are you happy just including the reference, which I think would be a great idea?
Yeah, I think, first of all, thank you for that. And I think that, there's language actually in the CDC paper itself that we could certainly use. And just reading from that, further research is needed to understand the performance of hemoglobin A1C and evaluate alternate tests in place of the hemoglobin A1C in specific African descent populations, especially Afro-Caribbean. I mean, and that's
John,
directly from the paper.
Does that sound okay to you, John? So we'd add the reference and that statement right after effectiveness?
Bill Herman, can I just jump in for a second? This is Dean. I think, Barry, you're raising a very important point, but I'm worried that including it in this way may limit the scale and impact of your point, because this issue with hemoglobin A1C, while absolutely introduces bias with respect to one's descent, is also an imprecise test for people of all race ethnicities. And so I'm wondering, we have a statement in the research recommendations where it may be more appropriately positioned to make the point that you're making, while not limiting it just to African Americans in terms of the critique.
Yeah, Dean, thank you for that. I actually had considered that, and the question really came about of trying to be faithful to the content of the specific reference. But in fact, I completely agree with you, and there is a body of material speaking to the concerns or imprecision of hemoglobin A1C across a number of ethnic groups. So I think that provided that we will call that out specifically as a research need, and again, I would ask that we include this reference in that section. I'd be very grateful for that, and I think it would serve the commission and the readers of the report well. Over.
So the recommendation is to leave this here as it is now, but to add the reference in the research recommendation. Is that correct?
Well, can we look at the research recommendations?
Sure. Jennifer, can you go to that?
So this is the type 1 diabetes prevention research here.
No, so that's not what we mean.
Right. So the research ones were at the end of the chapters.
Right.
And so this is the type 2 diabetes prevention research. So these are the two research recommendations.
Show us the bullet points, please. Show us the bullet points.
Right. So the bullet points are these here.
So I think that within the constraints of the document as it's structured, this would be the appropriate place to insert that text. Dean, to your point, perhaps the language that's actually in the CDC paper might be modified just for purposes of this document to say something along the lines of further research is needed to understand the performance of hemoglobin A1C and evaluate alternate tests in place of the hemoglobin A1C among various ethnic groups, something to that effect?
Yeah, I actually had thought that this. Yeah, I actually had thought that this statement around more research was actually embedded in a recommendation as opposed to the background. So I agree with you, Barry, that what you're suggesting would be a more appropriate way to shape the recommendation, because this sentence is a recommendation.
Right. So we would add that sentence under recommendation 512, is that right, as a first bullet perhaps, where there are already 4?
We've went over this, and Howard was very against adding hemoglobin A1C in this recommendation. I'm trying to remember his exact argument, but we feel like our understanding of this is changing, and we didn't want to muddy the waters by including that in the recommendation. I'm trying to look where we've talked about that in the background and supporting information, but we feel like this issue is not one to involve Congress in a specific recommendation. That's gonna work itself out. The big problem is not that we're not doing hemoglobin A1C. The big problem is we're not doing anything. 18% of people have been diagnosed with prediabetes. We need to get that number way up. So we really didn't want to muddy the waters. We feel that most physicians know and understand that there are variations in hemoglobin A1C. Everybody I know knows that. So that's not the main point or the main issue.
Yeah, so Barry's point, though, there were really 2 issues in that. One was other biomarkers, and then one was exploring A1C further. I'm sorry. Go ahead, Barry.
No, I I think that whether or not the commission sees fit to make this a recommendation, I defer to the wisdom of the group. I think this is an important point. Pat, CDC considers this an important research need. Is that correct, based on that paper?
Yes, that's correct.
So I think that the content should be in this report, and whether the commission chooses to make it a recommendation or chooses to acknowledge it in the content just above the recommendation, where we identify where research is needed, I do feel that this should be in there. Over.
And I think it's consistent with our statement of including health equity in policy recommendations.
John, what do you want to do?
Yeah.
Yeah, I thought we had put something in the background to that effect, and I'm just trying to look for it now. So I totally agree, and Howard does too, in including that in the background. But I'm trying to look to see where we put that. It might be one of those that we thought we had passed on and didn't. But I think both Howard and I would agree with including that in the background.
And we would add it after effectiveness, correct? It would be, now that would become the last sentence in this paragraph. Correct?
So the thing is, if we do that, I just think we want to make it clear that that's a new point, because the issue that's being discussed there, while it's very important, is in my mind very distinct from the concept of pathophysiologic heterogeneity. And I wouldn't want the 2 sentences to be sort of, melded together. They're totally distinct.
I agree, Barbara, and I think there's one way we could do this is to say more research is needed, blah, 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 and then the sentence ends, and then says something like, and assess the performance of these screening intervention across race, ethnicity, something like that. And then put in the reference that Barry is mentioning. Would that address the concern, Barbara?
Yeah, I'd like to see it written out. Sorry, it's hard.
Yeah, so Dean, say it again. So you said effectiveness and assess.
This would be a new sentence after effectiveness.
Yeah, you don't want to run it together there. It almost belongs earlier in the background and rationale section as a separate paragraph.
Okay, assess.
I would say research to assess the performance of screening tests and efficacy of interventions across race ethnicity is also needed, and then put in Barry's reference.
That's fine.
Okay.
Thank you.
Okay, I have to tweak that, but
Yeah,
I'll get it off the recording.
Yeah, the efficacy of interventions across. Is also needed.
Across race and ethnicity is also needed?
Is also needed, and then put in Barry's CDC reference.
Yes. Yep. Okay. Is there any opposition to now adding this and the reference to above the background above the recommendation? Okay, so we'll make that change. And then there is another, so I think, Bill, here you wanted to change areas.
This is just wording. These are all questions, so I just said examples of questions for further research include.
We had that before, and we didn't want to get that specific, so we changed it to areas.
Okay, that's fine.
That was somebody else's suggestion.
Okay.
So we'll keep as is. Okay. Okay. And then Bill had added here acute metabolic complication. Complication. Sorry. Is there any disagreement to this addition?
We thought that was fine.
Fantastic. Okay. And then the last one, I believe, is Bill. And you were talking about, do you want to limit increases in funding? Why not say in the future annual increases in funding should at a minimum address costs of inflation?
It sounds like this whole recommendation is focused on making up for inflation, and I don't know that you want to limit the funding to make up for inflation.
Yeah, we agree with that. I thought that's what we had before, but so that's consistent with what we were thinking.
Okay, so you're okay to make this slight wording change, right?
Yes, thank you.
Hey, Bill, excuse me, it's Ellen. If we make this change with the SDP, shouldn't we make the change also with the SDPI?
Yes, where was that?
That's earlier.
And did we say was the wording identical to this?
I think it was.
Yeah, so we should say, put the same qualifier in there then.
Yeah, let's just be consistent. I agree.
So that's on page 68.
Thank you, John. All right, so we'll make that page, we'll make that change as well on page 68 too. And that brings us to the end of chapter 5.
Good. And a motion to approve the chapter?
Motion to approve, John Boltree.
Second. And all in favor say aye.
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 And all opposed say nay. All right. Good.
All right.
Next.
Fantastic. Thank you. On to chapter 6. So, Bill, for chapter 6, you had a comment about addressing, if you're going to mention stroke as a complication of diabetes, we should say chronic hypoglycemia can damage the heart, blood vessels, eyes, etc. So do you?
Yeah, I don't feel strongly about this. I would defer to Paul, but I would say hyperglycemia can damage the heart and blood vessels, eyes, kidneys, and nerves. These may result in heart attack, stroke.
The change is
none
fine.
of the earlier. Yeah. Okay.
The change is fine.
Thank you.
Okay. So did you say yes? So we'll make the change?
Yes.
Okay.
So I'd like, sorry, this is Dean. I'm sorry, I don't agree with the change. We've been through this, and I thought we had already established that hyperglycemia and cardiovascular disease, and particularly hyperglycemic reduction and cardiovascular disease, is very inconsistently associated with each other. I don't want to communicate something that is potentially inaccurate.
Well, so I'm not sure. I think we've had this discussion before. The evidence, I think, does support that hyperglycemia accelerates atherosclerosis.
As long as we're not suggesting that control of glycemia prevents heart disease, I'm fine with that.
Yeah, this is Paul. I interpreted it in the way Bill just framed it. I do understand the nuance. As worded, I think it's correct.
Great.
If you, on the other hand, I'm sensitive to your fear. It's a small, it's a nuance. I understand.
Yeah, I'm fine with it. Then I'm fine with what I'm fine with what I'm seeing. I'm not sure what it is that we're proposing we would insert instead of what we're seeing. Was there a motion to put something else?
Chronic hyperglycemia can damage the heart and blood vessels, eyes.
Oh,
so
you want to add blood vessels? Okay, that's fine. I'm fine with that.
Stroke, and heart disease doesn't lead to stroke, and retinopathy doesn't lead to stroke.
Okay. I don't know that blood vessels means anything to people in terms of stroke, but I get what you're saying.
Well, it may be relevant because a complication later mentioned is amputation as well.
Okay, so
let's move on. We're going to make the change, heart and blood vessels.
That's fine.
Okay. Okay. Thank you. Okay, so we're going to go
this is Barry. As we talk about some of the clinical nuances, are we thinking in terms of who the readers of the report are going to be? I'm just thinking about, some of the discussion we've had. Over.
Barry,
do you have a
recommendation here.
Barry?
I think we've assumed that this is going to be read by both a lay as well as a scientific but not diabetes audience, and that's why a lot of the wording has been written to potentially touch both of those. It's really hard to write to both audiences at the same time.
Understood. Thank you. Over.
Fantastic. This is, I think, just a copy edit from Dean, so that's fine. So Barry, you had suggested some additional, you recommend that the language be added in place of less informative, have periodically been revised.
Yes, and I can speak. This is actually relatively simple. So the current language is, the sentence reads, although NSD, SMES have periodically been revised, and I think just as a service to the reader, we can be more accurate in describing that. And so what I'm proposing is that the sentence read, the NSDS MES quality standards are reviewed and revised approximately every 5 years by a task force of key stakeholders and experts within the diabetes care and education community. A revised version of the NSDS-MES standards was released in September of 2017. These standards are scheduled for review again in 2022. It's simply a more accurate statement, and I think it provides more information to the reader in understanding this issue. Over.
This is Jasmine, and I just want to comment.
I'm going to defer to Jasmine and to Carol.
This is Jasmine. Barry, I want to clarify with your suggested wording as is, it makes sense and is accurate. I think the discrepancy that I was trying to kind of portray here is the discrepancy between the CMS quality standards and the NSDS-MES kind of that are a different set of standards. And I'm not sure if your rewrite kind of highlights that there are two different sets of standards that need to be reconciled here.
Yeah, thank you for that. I think
this is Carol. Oh, go ahead.
Yeah. Well, I was just going to say that the revised content only replaces the phrase, although NSDS-MES have periodically been revised. The rest of that paragraph would remain in place. And I apologize if that wasn't clear.
So I propose I think that information maybe could go up above the rationale, but even though the NSDS-MES have been regularly revised, each iteration must align with the CMS quality standards, which themselves need to be updated as they no longer align with evidence-based best practice. So kind of trying to clarify Jasmine's point, and I sent that by email to Jennifer. I don't know if you got it.
So that would stay in, correct? That's already there, isn't it?
It isn't. It's written differently now. So I put even though, I added even though the NSDS-MES have regularly instead of periodically been revised, each iteration must align with the CMS quality standards. Then I added which themselves need to be updated as they no longer align with evidence-based best practice.
This is Barry, and first of all, thank you for that. I think the additional detail that this is done every 5 years and how it's done, when it was last done, and that it's currently in revision, I think that is important content for a reader of the report, and I don't think it in any way weakens the point that these revised standards must align with the CMS quality standards, which the Commission asserts no longer align with evidence-based best practice. It really loses nothing, but it provides the reader with more accurate information in which to understand this issue. I don't see that there's value to the reader in obscuring that part of it. Over.
So there doesn't seem to be a disagreement, so I think we would insert Barry's language and Carol's revision, and I think that would handle it, right?
So what we would have is, so we would have Barry's, which says, you know, all the way down to these standards are scheduled for review again in 2022, right? And either we can keep even though, or we start with each iteration must align with the CMS quality standards, which themselves need to be updated as they no longer align with evidence-based best practices.
That would make sense. I mean, that would preserve your intent.
Yeah.
But it was Carol had revised that, and we should just use her language.
I did. This is hers.
I would keep the even. This is Sherry. I would keep the even though so that there's no confusion that, you know, we know that this is regularly reviewed, but each iteration. I think it's helpful to have the even though part. I know there's some duplicativeness, but I think it's useful so people don't get lost in the thinking like, why are we suggesting it?
Okay, so so what we've got on the table is that we would add this information from Barry, and then we would use the revised language from Carol, which is this piece here, and that would now become that it would replace this sentence that was here. Is there any disagreement?
Good, let's move on.
Fantastic. Okay, so Barry, you had some, I think, additional wording, right? You wanted it in the rationale.
Oh, no. Yeah, actually, it's not additional wording. It was really a question to the commission. So in this section, the commission asserts that the current CMS quality standards for DSMT no longer align with evidence-based best practice. And then the commission, having reviewed those quality standards, reviewed the literature, then concluded that the bullet points that follow are the recommended changes. And so my question was, and this is similar to the earlier discussion we had with Bill Chong about the FDA issue, that where the commission in its study of this identified evidence-based best practice, can we provide that in the form of references? So a reader could read the recommended change and then see where there was a reference to evidence-based best practice in the literature that they could then use to understand more about how that change was arrived at. Over.
Barry, I think I understand that, and I will say, and I think this can be fixed in a number of ways, that a lot of these bullet points listed here are known barriers that come directly from programmatic feedback, and from just, we know that these barriers exist at a program level. So I think where the discrepancy exists that you're mentioning here is because we called it out as evidence-based practices, you're suggesting that there be citations from the literature that say, because of XYZ, these are the recommendations that we recommend according to this citation. Am I understanding that correctly?
I think where the commission reviewed such evidence in making the recommendations, I think that would be, again, very helpful to the reader to understand how the commission made these determinations and what the evidence base was that was reviewed in support of these, where such exists. Over.
Okay, and I think we can end the discussion here, and I will look for the supportive citations as long as no one else has anything to add, and insert them where appropriate here.
Sounds good.
Okay.
So
Thank you.
Jasmine, this is Paul. I think the sentence that precedes Barry's comment here that ends the paragraph, these requirements should be reevaluated to align with current evidence-based practice, evidence-based care, I'm sorry. Maybe one or two references that cite evidence-based for DSMES would be added right there.
Okay.
And there shouldn't be any wording changes necessary.
Noted.
Thank you. Okay, so I think this was just is this just a word change, or, yeah, because you just want it involved. Okay. And then Barry?
If that's okay with Paul and Carol and their team.
Yeah, minor change, thank you.
Okay, fantastic. And then the next one here, Barry, is 6.3. So you were asking for a revision to 6.3. So your revision that you're asking for says the National Clinical Care Commission recommends that CMS use existing processes To update and regularly reevaluate at least every 3 years eligibility requirements for various diabetes devices leading to appropriate coverage determinations when there is sufficient evidence to support such national determinations. CMS should ensure that to the extent there are national requirements established, eligibility documentation reimbursement requirements are clearly defined and that they are consistently applied across all parties involved, including Medicare administrative contractors and auditors. In evaluating the data to revise eligibility requirements, CMS should evaluate the current published peer-reviewed evidence and consider both glycemic benefits and non-glycemic benefits, including patient-reported outcomes, which may include quality of life and diabetes distress.
Yes, that's correct. So, and basically just the additional content to add, again, the recommendation refers to CMS using existing processes to update and regularly reevaluate. This added language is just a more precise description of that, and again is a benefit to the reader in helping to understand sort of those dimensions that are called out here.
So I'm going to defer to Bill Chong. I know we have had numerous recent conversations about this, Barry, for concerns that you had about, one, that this was potentially going to supersede existing processes, and we've tried on a few occasions to modify the language to accommodate to that. So these are new suggestions. Bill Chong, your comment? Do you think that these change the substance of what is written?
Hi, Paul. Thanks. A few questions first to Barry. I just want to make sure I understand the addition. So I think the first addition I read about sufficient evidence, I think the point there is that if there's no new evidence, that we wouldn't ask you, the recommendation would not be to update at that point. Is that kind of the intent behind that addition?
I think the issue speaks to whether there is sufficient evidence to support the national determination.
Right. So the piece is that if in CMS's review they don't identify sufficient evidence to change the current determination, that CMS would just not do anything at that point. Is that how this would be implemented?
The sufficiency of the evidence speaks to the coverage determination, not the review process itself.
Right. So I'm just trying to make sure that you would review the process, but you would not find sufficient evidence, so you would not update or revise the determination.
I think if there were not sufficient evidence, the agency would not be able to do that.
Correct. Okay.
Correct. I mean, I don't think that the commission is suggesting that the agency would do otherwise.
Right. I just wanted to make sure I understood the intent behind the additional language there. And then the piece about to the extent where there are national requirements, where national requirements are established. This is I think we talked about this a little bit in a previous meeting, or maybe offline, about where CMS has authority over national coverage determinations, but local coverage determinations are sort of beyond the scope of what CMS can ensure in terms of the consistency.
Yeah, I think, and we did talk about this, and again, thank you for giving me the opportunity to be part of the evolution of this. I think that here it's the distinction that the Commission is well aware of between national coverage determinations, or NCDs, and local coverage determinations, or LCDs. And actually, this distinction is called out further on in the document itself. So here, it's making clear that that in this sentence we're speaking about national coverage determinations.
Okay, thanks. So I think, you know, this additional bit of language to me seems reasonable and kind of more refined in terms of the recommendation. The latter two pieces of language, I mean, I think which may include, to me that seems a little bit more of copy editing in style, but and the piece about published peer-reviewed, you know, I think when we were drafting it, we left it somewhat vague in the thinking that this would allow CMS discretion to choose what type of evidence they felt was appropriate to consider. And so that I think that was my thinking, at least. Like, we didn't necessarily need to specify, and CMS had discretion and flexibility to use the evidence that they thought was appropriate.
Yeah, and then this is Paul. I'll corroborate what Bill is saying, that as occurs throughout the recommendations, we tried to balance the fact of providing guidance but not providing specific direction, and clearly with regard to, for example, telling what CMS or suggesting CMS review the criteria. If there's no new evidence to revise the criteria, then we're not saying that they should be revised. Obviously, the discretion is at the basis of CMS, and same way with regard to reviewing evidence. If we specifically say they can only review peer-reviewed evidence, well, there might be unpeer-reviewed evidence. So, for example, material that's been submitted to the FDA that hasn't been published but yet is accessible. Might that be useful in their determinations and accessible? Yeah, why tie the hand if CMS has the ability to use their discretion?
And would you see the language as CMS should evaluate the current published peer-reviewed evidence and consider both glycemic benefits and non-glycemic benefits? Would you consider that as being completely prescriptive, meaning that the only data source would be published peer-reviewed? Because I don't read it that way, but I do see the reference to published peer-reviewed evidence as really establishing a scientific standard. It's certainly the standard I think that most of us use in clinical practice.
I don't think anyone.
I mean, if the commission, steps away from that.
Yeah, I don't think anyone's going to debate that, Barry. The question is, I'm assuming CMS, when it conducts its reviews, uses their best available evidence. We're not taking that away from the group that's going to review these data.
Right, I agree with you. So I think making reference to published peer review it's not binding the agency to only review that, but it's, I think, pointing out that, this sets a level of evidence that is very common in healthcare, and I assume supported by the commission.
Yeah, well, one way to get around it would be to use Bill Chong's current wording where it says evaluate current evidence, and maybe with a comma that says including published peer-reviewed evidence, comma, and consider both glycemic benefits, and so that is included but not necessarily doesn't bind.
I think that's a reasonable formulation.
So Jennifer, with Barry's concurrence, that statement and the recommendation, and Bill, would you accept that, or do you have some comments about that insert?
I was just going to say thank you for that suggestion, Paul. I think that seems to cover both bases.
Okay, so Jennifer, that line would say CMS should evaluate the current evidence, including published peer-reviewed evidence, comma, and consider both glycemic benefits and non-glycemic benefits.
Bill or Paul, this is Sherry. Bill, you asked the question of what is when there is sufficient evidence to support such national determinations referring to, like that whether they need to review it or even schedule a regular review. And I do think that there's some question, even though Barry answered it, how he was thinking about it. But when I would read this without Barry's explanation, I'm left going, so does that mean we don't need to review if we sort of decide informally that there's not sufficient evidence to even have a review? So I just bring that up. I think I feel like this last part in red is sort of, I don't know, I feel like it's self-explanatory that of course, if there's not evidence, you wouldn't update you wouldn't make any changes, you wouldn't make any edits. So I guess I feel like it adds text that might be more confusing than beneficial.
Yeah, this is Barry. I think the fact that we're having this conversation suggests that there is value in making that point. And the way that I read the sentence, when there is sufficient evidence to support such national determinations applies to the phrase appropriate coverage determinations or leading to appropriate coverage determinations. So I think that, again, bearing in mind that we're writing this for a diverse audience, I think that making that point is of value to the reader. Over.
Okay. Yeah, I think to Sherry's point, we heard time and again from stakeholders and patient advocates that the fact that the criteria for use of devices has not kept pace with the technology and the evidence broadly, that was limiting. And so the reason we made this recommendation was to say that there had to be a regular reevaluation, and reevaluation meant reviewing what was available, and if new evidence suggested indications needed to be broadened, so be it. If there was no new evidence, then everything was left as is. And so we want to make sure that that message is conveyed.
Yeah, agreed. And I think this sentence does that. Again, the added text is a response to leading to appropriate coverage determinations. Again, I know the commission doesn't intend that the agency would make a change in a coverage determination if there is not sufficient evidence. So I think that the current phrasing captures the value that you just expressed. Over.
This is Naomi. I think just because it's published in a peer-reviewed journal doesn't necessarily mean it is strong enough evidence, because we know that publications, can vary.
Yeah, Naomi, this is Barry. I agree with you. I think the desire there was to establish some sort of a standard, but I certainly I can certainly agree with that point. Over.
Okay, so I think we need to come to consensus on what this is going to say. So we have consensus on the latter part of the statement that includes the comment about peer-reviewed evidence. I'm going to go to Bill Chung. Do you feel that, if at all, do you feel the earlier part of the recommendation should be modified?
I thought that it was sort of implied that there needed to be sufficient evidence, but if there's any concern from CMS's side that maybe that needed to be more explicitly stated, I think as written, it seems appropriate. I don't know that I see any issue. I think what I heard from Sherry was that the concern that it would be impacting the sort of regular reevaluation, and I don't see that the language could be so confusing as to be read that way. So I'm okay with what Barry suggested for that first part.
Okay, so with the insertion of the words leading to appropriate coverage determinations when there is sufficient evidence to support such national determinations. And then CMS should ensure that to the extent that there are national requirements established, eligibility documentation.
Yeah, both of those seem reasonable to me. I don't have any specific concern with including them.
Okay. Others that participated in drafting this, concerns or concurrence?
Well, I think the first part is fine. I still have difficulty with emphasizing published peer review because there may be evidence that's not necessarily published that could be used, and there could also be published peer-reviewed work that aren't good evidence. So.
Yeah, so Naomi, I think that we tried to address that in balancing what Barry was trying to convey was that the statement reads current evidence, comma, including published peer-reviewed evidence, comma, which means that that's to be used but not necessarily exclusive.
Okay.
And
I was just reading the part above, sorry.
Yeah, no, and ultimately we defer to the reviewers as to whether or not they feel it's valuable. We're not prescribing that.
Okay, so there is agreement to use the verbiage that Barry suggested in the first part of this. I didn't hear any disagreement. Did you, Paul?
No, I think we have agreement with those modifications.
Okay. All right, fantastic. We'll move to the next one. Barry was asking if there was citations for who would benefit from access to diabetes technologies.
Yeah, hi, Barry. This is similar to the earlier question, and you know, we make the assertion that that the criteria for NCD and LCD are outdated and don't reflect current evidence. And again, as a benefit to the reader, can we provide citations or references that would link them to that evidence base? Over.
Yeah, hi Barry. This is kind of related to a comment that I'd made to Dean on the sort of the food thing about the data. And I think, you know, in trying to be judicious about the references, we didn't add any here. There's probably literally hundreds of papers that we could pull. I guess one approach might be to include a reference to certain respective medical society guidelines on this question, and they would, within their guidelines, include references to the different studies. That might be a more efficient way to kind of identify the evidence base.
Yeah, I think that's fine. I just, you know, if it's possible, I thought it would be helpful for there to be something here for a reader to be able to turn to better understand the point that was being made. Over.
Okay, so there sounds like Bill Chong, you'll send me over the guideline that has the references within it, right?
Yeah.
Thank you. Okay, so then Bill Herman, you said that this recommendation is too broad and you wanted to, which devices does this mean? And you had some other comments, and then Barry was asking for some other citations. So Bill Herman, do you want to kind of talk about what you were thinking here or how you wanted to have this rephrased?
Yeah, I think if you just read it, it sounds like pumps should be available to people taking one shot of insulin a day, and CGM should be available to non-insulin treated patients, and I'm not sure that that's what we mean. So it either needs to be more specific or dropped, I would think, or clarified.
Yeah, and I agree with you, Bill, and this is a concern I had raised at a prior discussion. It is too expansive, and I don't think our intent is that these sophisticated technologies get used for anyone with a diagnosis of 250.XX, you know, diabetes.
Hi,
So
this is
Paul
Bill Chong. Oh, sorry.
Oh, sorry, go ahead, Bill.
Yeah, so I'll let Paul and Carol chime in as well, but I think your point is well taken. I think that sort of like that level of possible interpretation wasn't something I had considered. And this is a list of examples. I don't know that it was intended to be sort of like comprehensive or capture all the nuances. I would be okay with removing this since it is specifically a list of examples, but I would also like input from Paul and Carol on this point.
This is an evolving field. Carol, go ahead. I'm sorry, please.
Paul, you can go ahead. I was just going to say that applies primarily to CGM, and because there's new evidence that patients only on basal insulin do have improvements in control and reduced utilization of ED and hospital. But as Paul was going to say, it's rapidly evolving, so I'm okay removing it. But Paul, go ahead and say what you were going to say.
You were going to.
Well, can
I was going to corroborate what Carol was saying as well.
Yeah, I was just going to jump in and say, I mean, one way to deal with it is right now it says examples of existing requirements that pose unnecessary barriers. It may be examples of existing requirements that may pose barriers to patients and providers. I wouldn't say unnecessary. I wouldn't say that they pose, but that they may pose barriers. Then we're not,
Yes,
you know,
yes.
being so strict.
Right. That sounds prudent to me.
Bill, you drafted this. Would that be sufficient?
Yeah, though you might want to change 3 then to for CGM rather than diabetes devices.
So this is Bill Chong. I think both those suggestions.
Bill.
Oh, no problem.
No, because this was Bill. I was imprecise. Bill Herman and then Bill Chung.
Yeah.
Carol, I'm going to just jump in. There is some evidence that when patients are very insulin resistant, that giving U-500 through a pump might help them even if it's not basal bolus. And then there's the new smart pens. And I don't know that you would use a smart pen in someone who's not on multiple daily injections. I'm just trying to think of the different devices. I don't know if it's better to remove it or to limit it to CGM. That was just what I was thinking.
I think we should just say what the barriers are and resist the urge to say we should remove it's just the field is evolving as what was described, and it feels too very specific without sufficient supporting evidence.
So Bill Chung, should that statement be removed, or as Dean suggested, maybe use the word may pose barriers and then correct the diabetes devices term to say continuous glucose monitor?
Yeah, I think I like both Dean's and Bill Herman's suggestions. I mean, I think as that second suggestion about maybe just highlighting the barriers and not talking about the approach to addressing them, that may also make sense. We have to. So I think, let me back up. I think for 3, it would be reasonable to be more specific here and focus on CGM. I think that, you know, again, as an example, this is an example of a situation where we think there's a little bit more evidence to support that.
Okay, so let me take what you've said and what I've heard. And so Jennifer, at the introductory statement to these this list, where it says examples of existing requirements, we'll change that may pose, and then strike the word unnecessary, that may pose barriers to patients. And then,
yep, we have.
Okay, and then for item number 3, at the end of it, instead of saying for diabetes devices, for continuous glucose monitors.
Yep. We got that too.
Thank you.
Okay.
Okay, we should move on.
I believe the next one is Bill Herman. You wanted the figure, the 11 billion needs clarification. What is the time frame? Is this per year? Are you okay leaving it like this, or what would you want changed, or how would you want it changed?
I think we can address this quickly. Sherry Boland, I assume that's $11 billion annually?
Yeah. Yeah, I'm almost positive. I can double check, but I was almost positive it was an annual.
So whatever
it is. Yeah,
so whatever Sherry says on that is fine.
Yeah. So that would be annually.
Per year.
Yep.
Or, yeah.
That is just, okay, so then the next one is Pat. And she wanted to revise the statement that is here. to revise it to recommend additional funding to CDC to accelerate efforts to engage and sustain CHWs by addressing system and policy level barriers to integration at the state level.
Yeah, and just to summarize, all I'm really suggesting there is that we not cite that specific cooperative agreement, which is State Public Health Actions, that long name. That cooperative agreement actually ended in 2018, and all cooperative agreements are time limited. So I think it would be just cleaner just to say, you know, recommended support or funding to CDC and not specify the mechanism.
Yeah, this is Sherry. I read your comment, Pat, and I thought it was a good one. So I didn't have a problem with it. I don't know if other folks had any concerns.
Okay, so Sherry, would you propose some alternative language?
I think she did, and up above, sick. I think it's all up there. Am I wrong in saying that?
It is. No, it does. It says this statement could be revised to recommend additional funding to CDC to accelerate efforts to engage and sustain CHWs by addressing system and policy level barriers to integration at the state level. So this whole sentence here would go away, and it would just be with what she recommended, because as she said, it was a cooperative agreement that's already expired.
So let me propose.
Although wait, can we just, so the reason that I just want to make sure, Pat, in our recommendation, we refer, can you go down really quickly to the bullets, to our recommended bullets? I just want to make sure, increase funding to CDC to expand programs to all states. Okay, so that'll still work. I think we were just trying to.
The recommendation is fine.
Okay. Yeah, that's fine with me.
The language you used in the recommendation makes a lot of sense. It was just the citation of putting it in a specific cooperative agreement mechanism,
right,
you know, that's already expired.
So this is Paul. Let me propose the following language. Strike the sentence that starts with one relevant CDC program through the end of that sentence, and then the following sentence, increase funding to striking this program and replacing it with CDC would accelerate the implementation and sustainability of CHWs by addressing system and et cetera. Would that meet your needs, Pat?
Yes.
And Sherry, are you comfortable with that?
Yeah, that's fine.
Okay.
Got it. Thank you. Yeah, that's just a copy edit. So this was from Bill Herman. You had said the middle paragraph, it was unclear what the comparator is for those with limited digital literacy or access. Telephone visits have shown equivalent benefits to what?
I'm okay with it as this is. That's fine.
It is compared to televisits, video visits, but I think it reads okay, actually. So.
Yeah, I'm okay with it as it is.
Okay.
Thank you. Okay, and then you just wanted to say more cost efficiently or something, so this is just a word edit.
Correct, if that's okay with everyone.
Okay. Acceptable.
Yeah, that's a format. Okay. So this one was yours again, Bill, about you wanted more clarification on what the sentence meant.
What page are you on?
97. It says, last sentence, we say research should be initiated by federal agencies to study new models of care delivery. What does this mean? It sounds like we're recommending that. You see it?
Yeah. So does that mean that federal agencies should do research, or that that federal agencies should support or fund research to study new ways?
Right. I think, Bill, your concern is the word initiated as opposed to funded, right?
Right.
Is AHRQ doing the research, or is AHRQ funding people to do the research?
Yeah, I mean, it actually could be both, frankly.
Yeah.
So maybe it should be
research?
or
could we say research Research should be supported. Research should be advanced by. Advanced by?
That would be fine too. Unless Bill doesn't address your point.
We recommend that federal agencies support research too.
Well, that is in the recommendation itself.
Yeah.
Yeah. Research should be supported, or federal agencies should support research to study new methods, new models of care.
That's fine.
Sounds good.
Okay, so say it one more time, Bill.
Restate
Federal
that, Bill,
agencies-
please.
Federal agencies should support research to study new models of care delivery.
You know what? It's funny that I'm just noticing the last two words of the previous sentence are federal agencies, so it'd be federal agencies, period, then federal agencies. So maybe the easiest thing would be to say research should be supported by federal agencies. Just take out the word initiated and put the word supported.
That's fine.
Yeah, exactly. So Jennifer, he's saying keep the yellow highlighted as it is, but change the word initiated to supported.
Got it. Okay. Thank you. Okay. This one is implementation research should address test new team-based care models and payment systems.
So this will go to Sherry.
This is Carol. I'm going to jump in. We had payment systems in there, and I remember Barb saying that, you know, that limits, not everybody's allowed to look at payment. So we had removed it.
Well, that was what I was debating. I'm not sure it was in there, but we had a whole conversation about it.
Yeah.
So
I think
I
it
know
was in, and we took it out.
That's right. I wanted it in, or in something. I can't remember, but I think this was an issue.
So Barbara, is that an issue if they add in payment systems? Is there any disagreement with adding those words here?
No, I mean, I think I was asked a direct question about whether NIH was allowed to do that kind of research, and we're not. But, you know, if it's generic about federal agencies and not directed specifically to the NIH, I don't think it's a problem.
And that's certainly something that CMS could do through CMMI.
Okay.
And we can put it in.
Okay, so yeah, we're going to add in payment systems to that.
So Jennifer, the payment systems is added in the last line to test new team-based care models and payment systems to improve diabetes care and outcomes.
Yep, that's correct. Okay, so that brings us to the end of chapter 6.
Yahoo!
Do we have a motion to approve the chapter? And a second?
I move to approve Chapter 6. This is Dean Schillinger.
And all
I second that.
All in favor?
Okay, so hold on.
Aye.
Aye.
Yes.
And opposed?
Aye.
So
Okay,
who was the second?
great.
Bill, who was the second?
I don't know.
Oh,
Does
I'm
someone
sorry.
want to take this?
That was Ellen Lee.
It was Bill Cook.
Oh, Alan. Thank you.
Okay,
Okay.
good.
Thank you, guys.
So,
Okay.
so Jennifer, we had public comment scheduled for 4:05, so 25 minutes ago. Should we cut to that, or what would be your preference?
Yeah, so we only have 2 public commenters. The other 2, their schedules changed and they are no longer able to provide public comment. So what we can do is go ahead and go to the 2. I can tell you who they are. It is Kate Thomas and Kate Curley. If we want to go ahead and go to them now. Oh, you guys don't move this slide.
Let's do that.
Okay, Kate Thomas, you want to go ahead and unmute and you can provide your verbal comments? Sure, I'm here. Can everyone hear me? Yes.
Yes.
Okay, thank you. The Diabetes Advocacy Alliance and its 27 member organizations have appreciated the many opportunities that the Commission has afforded us to provide the input for your deliberations and feedback to your ideas and questions. We applaud your efforts and the monumental amount of work that has gone into preparing your final report to Congress. We also applaud the impact we believe your recommendations will have on federal policy. The DAA is pleased to see the Commission seek to better understand and address the socioeconomic and environmental factors that continue to exacerbate health disparities in this country, as well as the focus on the role social determinants of health play in improving health outcomes for people with or at risk for diabetes. As the Commission prepares to submit its final report to Congress, the DAA stands ready to support the adoption and implementation of these policies and looks to the federal agencies around the table and on the call today to partner with us in these efforts. Specifically, these include advancing policies that combat health disparities and address social determinants of health, including looking to federal agencies to evaluate the impact on health disparities of each new policy related to diabetes. Urging Congress, CMS, and CMMI to make changes to the MDPP expanded model that will help to increase utilization of the MDPP among beneficiaries and ease the burden on suppliers. We believe this can be done by fully aligning the MDPP's requirements with those of the CDC's National Diabetes Prevention Program, like making virtual programs available to beneficiaries and removing the once per lifetime limit. Allowing CMS beneficiaries access to the full continuum of care to treat obesity, to reduce new cases of type 2 diabetes, and to help adults sustain weight loss in the longer term, including coverage for existing medications and services that can delay or prevent the onset of type 2 diabetes and its complications. Prioritizing that CMS provide coverage for hemoglobin A1C testing when used to screen for prediabetes, and endorsing and promoting the 2019 AMA proposed prediabetes quality measures related to screening for abnormal blood glucose by all federal agencies that directly deliver or influence the delivery of care. Exploring options to expand coverage for medical nutrition therapy to include individuals with prediabetes and obesity, removing barriers to accessing DSMT services, such as reducing the administrative burden related to providing those services, addressing known beneficiary barriers, improving referrals, and updating the CMS quality standards. Recommending regulatory reforms that would allow CMS flexibility to cover innovative diabetes technologies and services. The DAA looks forward to continuing interagency and stakeholder collaborations to improve access to care for the millions of Americans with diabetes, prediabetes, and obesity in this country. Thank you again for your tremendous efforts. It's really been a pleasure past the last 3 years. Thank you.
Great. Thank you very much.
And then we have Kate Curley. If you want to go ahead and unmute, you can present your verbal comments.
Hi, can you confirm that you can hear me?
Yes, we can.
Yes, we can.
Great. My name is Kate Curley. I am a family physician and director of chronic disease prevention at the American Medical Association, or the AMA. Thank you for allowing us to comment on the National Clinical Care Commission's recommendations. My comments today will reinforce AMA's previous written comments and address some of what we heard today. Overall, the AMA supports the comprehensive approach in the Commission's report. As a physician, I regularly see patients who would benefit from a multi-pronged intervention that addresses barriers to health behavior change and improves access to evidence-based treatments. The AMA supports a team-based care approach for both diabetes care and diabetes prevention, but recommends the Commission add, quote, physician-led to the recommendation. It is important to have the team led by a physician to ensure appropriate diagnosis and treatment plans. The AMA would like to reiterate its support for Medicare coverage of hemoglobin A1C tests for the indication of screening. This coverage is needed to align with clinical guidelines. While no screening test is perfect, hemoglobin A1C is generally preferred by physicians and is the most pragmatic test for screening patients. We appreciate the Commission's continued inclusion of all three measures from the AMA's prediabetes quality measure set. These measures were intended to be used together to incentivize comprehensive diabetes preventive care. The AMA will be reviewing its measures to ensure that they align with the updated USPSTF recommendation for screening for prediabetes. Regarding this new USPSTF recommendation, key changes include lowering the recommended screening age from 40 to 35 and recommending more options for evidence-based treatments, including metformin. Importantly, USPSTF recognizes prediabetes as a condition. The Commission's final report should reflect the work and recommendations of the task force. Additionally, the Commission should recommend that all commercial and public insurers should cover all of these evidence-based interventions. The AMA urges the Commission to recommend that the CDC Division of Diabetes Translation establish a system to track the outcomes of all evidence-based interventions for preventing type 2 diabetes and not limit it to the lifestyle change program and its weight loss metrics. The AMA appreciates the updated recommendation for improving the Medicare DPP. However, the AMA does not think that new model tests are needed and believes that CMS can fix several problems that threaten the existence of the MDPP through the Medicare physician fee schedule process or via statute. The AMA welcomes the opportunity to discuss our comments with the Commission and identify other areas that would benefit from the inclusion of organized medicine. Thank you.
Great. Thank you, Dr. Curley. All right, Jennifer, is that it then?
So yes,
Okay.
That's it, just those two. So now we'll go back. We've got chapter 7. This is just, I think, an edit from Dean. It should say develop and implement a national diabetes strategy. I think it's just word verbiage. Correct?
Correct, yeah, that sounds fine.
Okay, and then
That's
we
correct.
have, Bill, thank you. And then Bill, you had changed this, ensuring that those with prediabetes engage in. There were a couple of supports. Is there any disagreement with this change to the verbiage?
This is Paul. I might change the word engage to have access to. I know what the intent of saying it as engaged, but no national diabetes strategy is going to be able to enforce people to engage in lifestyle interventions, but certainly they can make sure that people have access to them. So Bill Herman, your comment? Or
Yes, I like that. No, I like that as well.
Okay, so it would say with prediabetes, have access to lifestyle prevention and intervention programs, right?
Ensuring that those with prediabetes have access to lifestyle intervention programs.
Yep, got it. Thank you. This is just a word. Okay, so that's it for Chapter 7. This is the only 2 comments for Chapter 7.
Okay, so is there a motion to approve Chapter 7?
This is Paul. I so move.
Second?
Meredith,
Don, still second.
And all in favor, please say aye.
Aye.
Aye. And opposed, nay. Great. Okay. On to the appendices.
Yes, so for Appendix A, so I'll just go through them one at a time. So Appendix A is the listing of the, public members or the special government employees, as well as all the federal. We've had just a couple of edits to make there, and then we go into the DFO and then HHS support staff. Appendix B is the each of the subcommittees. There were, I think, a couple missing, so we'll make those edits. We did include, like Ann Bullock, retired. We'll make sure it says that for PTP for Ann Albright, and I don't remember what David was on, but we'll go back to the records and see and just say he was previous. Then we go to Chapter C. So this is the summary of all of the commission recommendations. So if there were any changes in the subsequent previous chapters, we'll make them here as well so that they will match. And then from there, there's a lot of pages for the recommendations. Then we go into how each of the recommendations align with the charter or duties. And so those have been added here. There is an asterisk that says what each of the 1, 2, 3, 4, and 5 are so that you can go back and look at it. Okay.
Jennifer, this
Jana
is
had
Paul. I just want to provide, or if you can just provide assurance. In some cases, we edited the recommendations in the text, and I want to be sure that those get carried forward to these appendices.
Yep, they will. So we'll make them in the ones that I just showed you, which was the listing, and then be here that are in the grid. So whatever changes will be made here as well. And then Appendix D is the actual act for the NCCC. And then Appendix E is the charter. And I think here there's formatting, so we'll fix that. And then Appendix F is all the acronyms and abbreviations that we've used throughout the report. Yeah, and we'll add SCDI. And then Appendix G is all the references. So this will obviously change with the requested addition references that we've discussed today. So once those references are provided, we will add them to Appendix G, and some of these will be renumbered based on when they occur or appear in each of the chapters. Are there any questions or additional comments for any of these, the appendixes A through G?
Jennifer, how did the matrix get reviewed? So the charter duties and the recommendations, did a number of people go through them, and was there consensus on all of those?
Yeah, the co-chairs sent them to us, and we used what the co-chairs over for their chapter recommendations.
Okay, and so the co-chairs reached consensus, and this is, as long as they're okay with it, that's fine. All right.
Mm-hmm.
A question?
So go ahead.
Yes, I think it's Appendix D that shows the charter. It's signed by the Secretary in 2020. Should we have an earlier version of this? Because the commission started in 2018, or does it matter?
So typically we have the charter that pertains to the year that you're in, because otherwise, because the charters are normally updated every 2 years, so you want the latest chapter of the charter in the report.
Okay, thank you.
Jennifer, this is Paul. At an appropriate time, I wanted to just bring to your attention 2 typos that I noticed back in the executive summary. If that can wait until you're ready to just have me point those out.
Sure. Okay, so are there any other comments or questions about the appendices, or is there a motion to accept them, noting that the recommendations would be updated and the references would be updated based upon what was changed today?
I motion that. This is Bill Chong.
I'll second. This is Carol.
All right, and all in favor, please say aye. Aye.
Aye.
Aye. Aye. And opposed, nay. Good.
Okay, so then we go back. So the last piece is just the table of contents. Again, these pages will be updated, especially this G for the references. When those are added, if that number changes, we will go ahead and update these page numbers accordingly. I believe earlier, Bill, you had made a motion that you withdrew.
Yeah, and so that was an issue of including all of the commission members, including those who retired or were reassigned.
I think also, Bill, there was a request, and I had made it as well, for prior DFOs to be acknowledged here. And I'm specifically thinking about Clydette Powell as not being only relegated to the end of the report, but has been instrumental throughout the 3 years.
Hi, Dean. That request is going through OWH, and Clydette is being acknowledged in other parts of the document. So perhaps we can hold off on that vote right now.
Well, I think it would be good to get the sense of the Commission's preference in that regard, so that could be communicated through OWH.
I completely agree. I completely agree. I think that Clydette's involvement has been absolutely exemplary, and I think it would be nice for the Commission to be able to voice their opinion about that.
Yeah, and I think if we're acknowledging the commission members who contributed, even if they've left their roles with the commission, I think it would make sense. There were actually 3 other DFOs. There was Linda Harris, Jennifer Bishop, and Clydette Powell as well.
And do you have opinion, Bill, on are you asking that they also be included in this front page?
Real quick, so Clydette can be included as a technical advisor on the contribution because that's her role right now. Historical DFOs should not be listed on the contribution on this page.
I don't understand that, yeah.
But Clydette can be listed as a technical advisor because that's her current role.
We could then clarify this and list the DFOs by year.
Right.
That is not how that is not how it's usually done for the contributions in this section. So it would be unprecedented for this for the FACA document. This contribution should really remain for current members.
So this is Naomi. I do think that these are unprecedented times that we've been through, and by acknowledging all of the people that have been involved since the inception is very important to address that particular issue.
I agree.
And it would be straightforward then for each of these to put the years that people were involved if they've left.
Yes, that's a very good thought.
So the committee report, it should be about the work of the committee, not about the complexity of the federal management or the federal support of the committee. So it's really about the committee members. The DFO is a supportive role, so it's just listed there as the current who supported it when it was in its final path to the report. So historical federal support entities are usually not listed on this page. As I said, Clydette can be listed as a technical advisor, but it should really be the commission members, the work of the commission that is highlighted here with one supported role for the current support, the current federal management support.
Well,
I would like to
at a minimum,
I would like to echo what Naomi said. I think that we are in rather unprecedented times. I think the fact that the NCCC even had to move institutes, et cetera, I think there are some aspects of this that are rather, in my opinion, unprecedented. I think that Claudette's involvement was also unprecedented in terms of the commitment that she displayed, not only in her initial role, but in subsequent roles. And I would have to say, at least in my opinion, I think that that should be recognized as clearly as it possibly can.
Most of us feel the same way. Many of us feel the same way, put it that way.
So Claudette can be listed as a technical advisor. Claudette can be listed as a technical advisor here. Can we vote on, would we like to vote on that?
This is John.
I would, no, but
Can I
we're
make
not
a
going to
suggestion?
Vote on is DFO have been listed, all the people who serve at DFO been listed. Why is that not the consideration?
Right.
Or we could move the DFO to the appendix and list all 4 DFOs. The technical contributor, we've had 4 or 5 of them as well. So, you know, why would we just list one? And would it
Because
belong
Claudette is the
on
current, because Claudette is the current technical advisor. So it's the current supporting staff from the federal government. That's who's listed here. So it could be me as the DFO and Claudette as the technical advisor.
Well, I think a compromise.
Bill, this is John Boltry. Can we put in a statement of special thanks to Claudette for her contributions and help?
In the appendix, if you would like to do that.
So, I mean, I think at a minimum, Claudette should be included in this front page as a technical advisor.
She will be as technical advisor. She will be as technical advisor if that is what you would like.
What's wrong with listing everybody by their years? I don't understand that.
What is wrong with that?
Because, you know, you may have taken us to the end, but what's really important is the fact that we got off the ground.
Yes.
And managed to make all of
why
those
it would be, why it would be listed here is for Claudette as the technical advisor, me as the DFO, is this is for the current federal support personnel to be listed here.
The title of this page is contributions. It is not current federal membership.
Correct.
Are we able to take a vote on this? Can somebody
take a vote on it?
And take a vote?
Yes. Also, I have one further question before we vote. If there is going to be a special section of acknowledgement of Claudette, where would it be located, and would it be explicit about the fact that she was the one that got us up and running and started it and got us to the finish line?
Jennifer, where would you suggest that would be put?
So we have, oh no, I got to get to, sorry, I have to get to the appendices where they are now. So you could make, so this is the listing here. I think it is, yeah, so this is A, where it talks about the National Clinical Care Commission, and it has everyone listed, including the Fed, and you could put some additional text here underneath the HHS support staff, either before or after Claudette's name here.
So there are two separate issues on the docket to vote? Is that right?
I would move to have it on the front page. Even if you say it's not the way it has been done, we are in different times. And I
So what is your motion, Naomi? What is your exact motion?
So my motion was to include everyone on the first contributions page, because I view it as contributions over the past 3 years, and do think that even though things have been done differently in the past, we have to agree that things have changed. So
I second that motion, and I I second it on the basis of basic human decency.
Yeah.
So, and so the recommendation would be to include all of the commission members, including the 3 who have been reassigned or retired, and to include all the designated federal officers, correct?
Correct.
Yes.
That is what the motion is about now. Yes.
Yes. And
Okay.
they would appear in the order in which they served, meaning that Claudette would be the first on the list.
Or third.
Okay, and should we put the commission members before the designated federal officer?
Not necessarily. Maybe the designated federal officers would go first in the order in which
Okay,
they
that's
served.
fine. Okay, so we have that motion. Should we do a voice vote, Kara, or do you want a roll call vote?
This whole time we've been doing a voice vote, so it should be a voice vote.
Okay, so all in favor of that motion, please say aye.
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 Aye. Aye.
And all opposed, say nay. Okay, so it sounds like we've decided that.
Can I ask, this is Sherry, I think I'm remembering Dean's emails, and since we're talking about contributions, would it be worth having the subcommittee chairs listed as subcommittee chairs after their name under commission members?
I would be in favor of that.
Yes, I think that would be fair given the extent of their contribution. I think that would be a good idea.
So how would you phrase that? Would you just put subcommittee chair or subcommittee co-chair, or would you specify the subcommittee?
I think subcommittee co-chair, because later on in the appendix it goes into detail.
Does anyone have any comments on that? So do we have a motion to, after the subcommittee co-chairs, to acknowledge that role?
I make a motion to acknowledge that role.
Okay.
I second it.
All right, so all in favor, please say aye.
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 Aye. Aye. And opposed, nay? All right, great.
And I would like it to make a motion aligned with, I believe, Merida's comment about having an acknowledgement statement at the end of the appendix in special gratitude to Claudette Powell.
Any discussion of that? Do we have a motion?
I motion.
Second? I'll second it. All in favor?
Aye.
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 And opposed? Great. Okay. Anything else on this now?
No, we just need a motion to accept the table of contents as motioned and revised during the meeting.
Okay, do we have a motion?
So moved.
And a second? All in favor? Aye.
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 Aye. And opposed?
Aye.
Okay, good.
So that brings us, we are done with the report, Bill?
Jennifer, Paul Conlon,
Okay.
could I just bring us
Oh, yes.
briefly back to the executive summary? Maybe two very quick edits.
Oh, yep. Yeah, I forgot about that, Paul. I'm sorry.
Yeah, my apologies. So page 1, hopefully there's a right just below that. In the 6th line where it says 2021, it should say National Clinical Care Commission. After all, that is our official name.
Yep. Yep.
Surprised that people didn't see that. Goes to show you, to read something quickly, you see what you want to see. And then in the second paragraph down under prevalence and health impact, it uses the word COVID a few times. The official word is COVID-19, COVID-19. So those are two very minor changes.
Okay.
Thank you.
Yes. Got it. Thank you. Okay, I'll stop share, Bill, and then go back to the slide deck.
Okay. Good. So I think we've had a productive meeting. Jennifer, can you help us or Kara with the next steps in terms of what your timeline is to put it together and whether we will see or what we will see again?
So our task is to take the changes from today and then the references that were requested to add them into here. We'll do another round of copy editing and then provide to OWH to send through courtesy clearance. We will make a 508 compliant document and send that they can send to Legislative Affairs, which will then distribute the report to Congress and the Secretary of HHS. And all of this was done before. Sorry, go ahead.
Right. And by September 30th, right. And is there an opportunity for a couple of people or a handful of people, if they would like, to read it for typos and formatting and those sorts of things?
That is not built in because of the courtesy clearance, but we can work with OWH and the comms and see if that can be done.
So when it goes for courtesy clearance, it presumably could go to the commission members if a handful of folks wanted to review it one last time. Do we have any volunteers, or do people think that that would be worthwhile?
Bill, I actually have a related question, which is what is the process of editing that may or may not transpire during the courtesy clearance and the Office of Legislative Affairs clearance? What does that entail, and what should we anticipate, if anything?
Good point. So I thought the courtesy clearance was a chance for them to look at it. Is the intent that they would have an opportunity to change anything?
Hi, sorry, I was on mute. I was answering your question, Dean. So the courtesy clearance, it will go through, and all agencies that are mentioned in the report, they will be able to see the report. Now, they can't give us any edits to change anything that isn't egregious. So what that means, anything that is not true, and it'll be minor copy editing. So if they find typos, things like that, they can let us know. But they cannot change content unless it's factually inaccurate.
And is that also true for the Office of Legislative Affairs?
They don't clear it. The Office of Legislative Affairs sends it to Congress.
I see.
So would we be able to see any egregious errors that they found to just understand what they were and how they might have occurred?
Yes, of course. This is a very transparent process. We will let you know. We understand you've worked very, very hard for the last 3 years in this report, and your dedication is appreciated. Of course, we will let you know. As far as reading the report, we will have to check back with FACA, and when we schedule the meeting on the 20th, we can discuss it then.
Okay, so presumably it would be circulated. When would it be circulated for courtesy clearance? Because it would seem to me that that would be the time for us to look at it again.
Circulated for courtesy clearance or circulated after courtesy clearance? I thought you wanted to read it after they had reviewed it.
Well, you said there wouldn't be change. You said there wouldn't be changes made unless it was egregious errors.
Well, okay. So it is set to go. It is set to go through courtesy clearance on the 18th. That's the estimated timeline, and we will let you know if that, on the meeting of the 20th, we will let you know if that timeline has been met. And then we'll also let you know if we can let members who are interested in reviewing at that time.
Okay. And so please think if you would be willing to review it and let me and Jennifer and Kara know now if you think you might have the time to be able to do that. Okay. Were there any other questions on the timeline?
I just had a question about the September. Go ahead.
No, you go.
I just had a question about the September 20th meeting that we're having in terms of dissemination plans. Kara, could you clarify that?
In what regards?
No, your email to me said that we would be meeting on September 20th, so I'm not sure what that was.
Oh yes, I just stated on September 20th we will discuss with the co-chairs and ask for feedback for any dissemination plans. For
and will we be
stakeholders that would like include.
Will we be presented the dissemination plan that we can respond with feedback to, or are you asking us to present a dissemination plan to you at that time?
We will be discussing the dissemination plan and get your feedback. So feedback such as stakeholders, any other content that you think we should consider. So it would be a meeting with the co-chairs to get your feedback and discuss our plans for dissemination.
Okay, and I think that actually is the next thing that I wanted to talk about, Kara. Would you just say a few words about the role of the Office of Women's Health and the Assistant Secretary for Health in terms of the dissemination plan?
Yes, so the dissemination plan will be finalized with the collaborative efforts of OWH and the OASH Office of Communications. So for the sponsoring office and then the agency office, this is how it's done for FACA reports or any products of a FACA. The rollouts are done with the collaboration of the sponsoring office and then the agency's communications office.
Okay, did you want to say anything more about that at this point? Or I had 3 slides I wanted to show.
No, because that's, like I said in my emails to you and the co-chairs, that we will be meeting on the 20th to discuss the plans and get your feedback about the plans.
Okay. And will this call be open to any of the commission members who would like to attend? Because I don't want to shut out anyone who wants to be engaged. And I think,
like I said, great question. And I did answer it in the email. So if the committee members that are not co-chairs or not the chair, if they have any feedback or particular stakeholders or organizations that they would like included in the dissemination plan, to let either you as the chair or other co-chairs know, and we can discuss that on the 20th.
Okay, and I would just make the point that I think it is going to be critically important that all of us do whatever we can in terms of facilitating the dissemination by going to our local Congress people and senators and and trying to get the word out, though obviously it needs to be done only after the report is sent to the Congress and with the guidance of the Office of Women's Health and the Office of the Assistant Secretary for Health. Can I'm off the website now, but can you show my first slide actually about the draft dissemination plan?
Actually, we've had an email exchange about that because that draft dissemination plan is different than actually an OASH FACA dissemination plan. So as I stated on my email, and also in the capacity of going to your policymakers as the report, before the report is finalized and before it is submitted to Congress, you cannot go to your policymakers in the capacity of a FACA member. You can state it in your biography, but it can't be prominent. You can state it in your biography that you are a member of this FACA, but you cannot go in an official capacity as a member of this FACA. You must do it on your own personal time.
Right, thank you, and that was the point that I was trying to make. So do you have the slide, Jennifer?
That slide is not available.
Okay, so just in terms of thinking about the draft dissemination plan, we thought it would be important to have some sort of kickoff event and actually to be working on developing a PowerPoint slide set that members of the commission could...
Hi, Bill. Hi, Bill. Can we not discuss the draft dissemination plan, your draft decision plan here? Because as I said in the emails, and as I have stated here publicly, the OASH Communications and the Office on Women's Health are responsible for producing the dissemination plan and for finalizing it. So any draft dissemination plan that you have right now may not be on the same lines as what the OASH Comms Office and what OWH will be putting forth. So as I stated on my email, we will be having a meeting on September 20th, and we will discuss the dissemination plan there. And we will listen to your feedback and your thoughts on the dissemination plan at that time.
So does everyone still have September 20th on their calendar? We had tried to maintain that date. Is everyone still available for that meeting?
What time is that planned, Bill?
I don't know. What time is that planned, Kara?
We are scheduling it. So Jennifer's in the process of scheduling it with the co-chairs and yourself.
It doesn't sound like the rest of us are invited.
Well, and so I don't think that...
There's no reason that the rest of us should not be invited. This should be an open invitation.
It's a meeting with the co-chairs and the chair, and they can have feedback with you by email, but this is the last public full commission meeting for the NCCC. The other meeting is... The other meeting is a courtesy meeting.
We've been working very hard for the last 3 years.
It's very important to ensure that the report is finalized and sent to Congress and sent to the Secretary as congressionally mandated. That is the important component here, is to make sure that you meet your congressional mandate and your congressional statute, which is to have a report submitted to Congress on September 30th and to the Secretary. The dissemination plan is the responsibility of the Office of Women's Health in collaboration with the OASH Communications Office. This is a FACA document. It's a federal document. It is not a committee-owned document. It is a FACA document to Congress and the Secretary. The dissemination plan will be done through the Office on Women's Health in collaboration with the OASH Office on Communications. As a courtesy, we will be meeting with the chairs and co-chairs to discuss the dissemination plan and get your feedback, such as what stakeholders should be included. And if the other commission members would like to send you emails stating the other organizations and stakeholders they would like to be considered included in the dissemination plan, that can be done. But this is a courtesy meeting with the co-chairs and the chair.
So Kara, this is Paul Conlon. Maybe you could just clarify for the group that because of FACA regulations, that if the meeting is open to all of the commission members, then it's then subject to all of the notification, publication, and announcement requirements. So I think that the message that people were hearing was that they weren't welcome, more so that if this then becomes a formal meeting of the full commission, then it's subject to all of those FACA regulations. Is that correct?
Paul, thank you so much for checking in and stating that. Yes, that is correct.
So I don't think...
At this point,
I was just going to say, I don't think the intent was to intentionally exclude people, but because this is now an ad hoc meeting, if it was published as everyone was, it was going to be a full commission meeting, then it would be subject to the FACA rules. But I'm assuming that since it's a co-chair's call, that if co-chairs feel that one or more members may be interested in listening in, those could be done, those invitations could be done ad hoc.
Yes, thank you, Paul, for explaining that in a way, everybody, that I couldn't. Thank you.
But I'm hearing Paul say that if there's a particular subcommittee member that's interested in participating, we could extend an invite to that person as an ad hoc participant.
Yes, if there is a reason that that person has to be there, yes.
Okay, thank you.
Well, the reason is they've been a part of the commission for the last 3 years, but
that's not a valid reason. That is not a valid reason.
So I would just like to point out that for the last 6 months, I have felt that we should have a September 20th or 21st meeting, and that has been summarily rejected and consistently rejected. And I think this is a good example of why it would have been good to have had a meeting so that we could have gotten the entire input from the members of the commission.
So, Bill, now that the report is finalized and the votes are finalized, the work of the committee through the congressional statute, the congressional language, is complete. You all have done a tremendous job with this report for the 3 years that you have dedicated on this, and now you have met your statutory requirements.
Will we be receiving a copy of the final report?
Yes.
The final report, once Congress has accepted, will also be on the health.gov website where the NCCC is already listed. That will also show there, which would also be a 508 compliant file that can be downloaded as well.
Any other thoughts or discussion on the dissemination plan?
This is Dean. I would just say, given the constraints that we just heard and the opportunity that we just heard, it seems I would just like to say to all commission members across the subcommittees, if you do have ideas about dissemination, including but not limited to stakeholder organizations or individuals to whom outreach can be done, to please communicate with your subcommittee co-chair or the chair of the committee so that we can best represent everybody at that September 20th meeting and create, put the best input possible to what I'm sure will be a very comprehensive communication plan.
Good. All right. Well, to wrap up, then, I want to thank you all of the non-federal and federal members of the Commission for your enthusiasm, insights, and hard work. I'd also thank Jennifer and Communicate Health and Kaufman and Associates for their technical support. Want to recognize Don Wright and Rick Olson, who formerly provided oversight to the Commission, and to all of the designated federal officers, current and past, including Clydette Powell. Also to our former members, including 2 former co-chairs, Ann Albright and Ann Bullock, and David Wong as well. And also the professional organizations that have helped us in our work, including the 2 that provided public comment today, as well as all of the others that provided support and formal feedback on our work. So I will turn it over now to Dorothy for her closing remarks.
This is Barbara. Could I just say one thing? Could we acknowledge, appreciate, and thank Bill for his leadership?
Absolutely.
Great idea. Here, here.
All right, Bill.
All right, Bill. Thank you.
Oh. Yes, and we agree. We would like to thank Bill for all of the hard work and all of you on the line right now. So thank you all. We would like to share our deep appreciation for the work you all have done over the course of this commission to improve outcomes for those at risk for diabetes and those who are already living with this disease. I definitely have appreciated all of your discussions as an endocrinologist and really appreciate all of the work that you all do, both with this commission and back with all of your patients and with all of your other physicians that work to impact the lives of people with diabetes. We really appreciate the importance of coordination of federal programs that really focuses on equitable healthcare for all. And we're really happy that OWH was able to sponsor the NCCC during its final year to ensure that the commission successfully completed its congressional charge. You know, to follow up on what we had said before, you know, we really want to acknowledge the chair, Bill Herman, as well as the co-chairs, John Boltrey, Paul Conlin, Carol Greenlee, Aaron Lapata, and Dean Schillinger, and Howard Tracer for all of your leadership and guidance. We would also like to thank the OWH staff who worked with the commission, and we definitely wish we were in person, but we appreciate a virtual round of applause that we wish we could have in person for sure. The report that you finalized today will lay the foundation for the collaborative work to strengthen the federal public health infrastructure and improve health equity across the nation. As you heard from Dr. Levine earlier, this is a huge priority for HHS leadership, and we're so excited to be able to submit this report and the next steps. All of us at HHS are incredibly excited about the prioritization of health equity work, and we feel that we have an incredible opportunity to set the landscape towards prevention and health for all, including those with diabetes who already have it or are at risk for this condition. The vision for Healthy People 2030 is a society in which all people can achieve their full potential for health and well-being across the lifespan. And we truly believe that your work, as we conclude today's meeting and release the final report, are several large steps towards making this a reality. So we thank you all and look forward to the next steps.
Thank you.
Thank you.
Yes, yes. And we wish you the best in your future work again as you all conclude this and get back to all of the other posts that you hold impacting people with diabetes. So thank you again. We really appreciate all that you've done.
Thank you. That was very nicely said. May we have the round of applause that you suggested?
Yes. Absolutely.
Yay. Yay.
now closed.